Okay, now go meeting start here. The first session. Good evening and a happy new year 2021, and I welcome you all delegates to the first session of the CME Meet the Professor 20 most important points in clinical neurology. Respected Professor Dr. Madhusudanan sir, he will be the main speaker and talking to you, and the session will be chaired by Professor Dr. M.A. Andrews, HOD Medicine and Principal of Government Medical College Thrissur, who will also our own executive committee member. Request all participants to put your questions in the chat box before the end of the session, and selected questions will be answered depending upon the time permits. Expecting your kind cooperation and sincere participation, and once again welcome you all to this knowledge hub. I invite Professor Dr. M.A. Andrews to the chair. എൻ്റെ ഒന്ന് സ്ക്രീൻ ഷെയർ ഞാനൊന്ന് ആയിക്കോട്ടെ മൈസെൽഫ്.
सिर्फ ₹1 में पूरे महीने के लिए और अपनी रजिस्टर्ड मोबाइल नंबर से फ्री मिस
Can I start?
Okay, 1 minute. Let me introduce yourself. Professor Dr. M.A. Andrews, MD DM, Neuro, Professor and HOD, Medicine, Government Medical College, Thrissur. He did his MBBS and MD from Kottayam Medical College, DM from Trivandrum Medical College in 1993. Had a training course in leprosy, CLRTI, Changilpet. Started his career as a medical officer at Damian Institute, Thrissur in 1981 to 83. Became a tutor in medicine at Kottayam Medical College. Then assistant professor in medicine, then associate professor, vice principal, and now the principal of Government Medical College Thrissur. He was the secretary of IMA Thrissur branch, Kottayam branch, and past president of Diabetes Club, Physicians Club, and Neuro Club. He had given a lot of original papers and reports, edited and co-edited with many other faculties. Incidents, predictors, and outcome of intermediate syndrome in cholinergic insecticide poisoning, a prospective observational cohort study that is published in September 2013. Then another one, osteomyelitis varicolosa, that is in Rheumatology International Journal in September 2011. Then comprehensive myelopathy caused by isolated epidural myeloid sarcoma with systemic mastocytosis, a rare presentation of a hematological malignancy in 2014 along with others. Then screening of patients with acute febrile illness for leptospirosis using clinical criteria, serology and PCR, an STS project of ICMR guide by Dr. M. Andrews. Then clinical profile of acute undifferentiated febrile illness in patients admitted to a teaching hospital in Kerala. Then intentional subcutaneous injection of elemental mercury when he along with Dr. Cyril Jacob at Government Medical College Thrissur. Then mortality predictors of leptospirosis. Again, a study on the pattern and risk factors of stroke in patients from Central Kerala Another one, a case of hemophagocytic lymphohistiocytosis presenting as pyrexia of unknown origin. He had another research project, ICMR, accepted in 2014. That is, title of the project was Acute Febrile Illness in Kerala, a multi-center study, and many more. So I welcome you, sir, for this webinar, and handing out to this chair and having the mic to you. Please take over, sir.
Good evening, all. First of all, I would like to thank the organizers for giving me a chance to chair this session, where the main speaker is my own teacher, mentor, and everything in neurology, our Madhu sir. My duty is to introduce Madhu sir to this august audience, and I think all of us are well aware of Madhu sir and his contributions. He is Professor and HOD of Neurology at Travancore Medicity, Kollam. He is Adjunct Professor of Neurology at Manipal Medical College. He is a consultant neurologist at PRS Hospital, Professor Emeritus Medical College Trivandrum, and he is a Professor and HOD of Medical College Kottayam. He has got several publications, more than 36 publications in national and international journals. He has contributed 15 chapters in textbooks of neurology and medicine and published a book, Higher Neuronal Functions. It is said that an average teacher tells, a good teacher demonstrates, and an ideal teacher makes you take up that subject. I think Madhu sir has been pioneer in neurology at Kottayam, and many of his students have been attracted to neurology by his magical way of presentation and also the discussion. And many of us are his teachers. I mean, many of us are his students. They are also attending this conference. And I think I should not stand between you and Madhu sir. And I am extremely honored and humbled as sir is doing the main presentation here. Over to sir.
Am I audible to you all?
Yes, sir.
Yes, sir.
Am I audible?
Audible, audible.
Yes, sir. Audible.
First of all, I would like to thank Professor Andrews for his kind introduction. I have no words to thank him further. I also like to thank the IMA organizers, especially Dr. Joy, Dr. Ramkumar, who was for this. Now, without wasting, I'll start sharing my screen. Is my screen visible?
Yeah, it is coming.
I think it's visible now.
It's coming.
It's
I started screen. Started screen sharing എന്ന് കാണിക്കുന്നുണ്ടോ സാറേ? സാറ് പോയാ? സാർ മ്യൂട്ടഡ് ആണ് കേട്ടോ. യു ആർ മ്യൂട്ടഡ്. connection problem. എന്തെങ്കിലും പ്രോബ്ലം ഉണ്ടോ? യു ആർ മ്യൂട്ടഡ്, അൺമ്യൂട്ട് ചെയ്യൂ. യു ആർ മ്യൂട്ടഡ്, പ്ലീസ് അൺമ്യൂട്ട് യുവർ സെൽഫ്.
അൺമ്യൂട്ട് ചെയ്തോ?
അൺമ്യൂട്ട് ചെയ്തിട്ടില്ല ആള്. ഡോക്ടർ മധുസൂദനൻ സാർ, അൺമ്യൂട്ട് യുവർ സെൽഫ്, അൺമ്യൂട്ട് ചെയ്യൂ. കേട്ടൂടെ ഒന്നും?
സാറിന് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റില്ല സാറേ. ജോയ് സാർ
ഇവിടുന്ന് അൺമ്യൂട്ട് ചെയ്യാം.
അവിടുന്ന് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റും, അഡ്മിന് ചെയ്യാൻ പറ്റും.
ഞാൻ നോക്കിയിട്ട് പറ്റുന്നില്ല.
Okay, am I audible to you now?
Now it is
Yes,
on.
yes sir.
Okay. Is my screen visible to you?
Yeah, now
yes,
it is
sir.
coming. Yes, now
Okay.
it is.
So sorry for the delay.
No problem.
So I would like to thank Dr.A.Andrews and IMA and Dr. Joy, Dr. Ramkumar for inviting me to this prestigious lecture. I have been asked to talk about the 20 most important points in clinical neurology. What I have decided is little different. I have chosen 4 most common problems which is come across by physician in their day-to-day practice. That means one is vertigo, another is episodic transient loss of consciousness, and a person coming to with weakness, another person coming with some sensory symptoms like paresthesia. I'll come to the first point. This is in terms of presentation is like a question answer session. First topic is dizziness and vertigo. How do you approach the problem? Many patients come to the history of so-called vertigo as an isolated symptom, and we are at times at loss to differentiate whether it's true vertigo or not. In that situation, what are the questions you would like to ask to clarify the issue? No, in fact, the term talagarakam is not equivalent to vertigo. In fact, this is the most commonly abused word in neurology. For a person, each and everything is talagarakam. It may mean a dizziness, a heaviness of head, feeling of imbalance, ataxia, blurring of vision, diplopia, or even loss of consciousness. So the first task is whether the symptom in question is in fact a true vertigo or not. The descriptive symptoms can help to differentiate to a large extent. The sensation of spinning, sensation of feeling drunk, sensation of motion sickness, feeling of falling to one side are symptoms suggestive of true vertigo. On the other hand, spinning sensation inside the head, floating sensation, swimming sensation, and feeling of near painless are not true vertigo. They suggest a non-vestibular dizziness. But however, some people with true vertigo may not give the spinning sensation. They only say dizziness or some other imbalance like that. In that situation, how to differentiate a particular symptom is true vertigo or not? If the symptom has got associated autonomic symptoms like vomiting or sweating, that is more likely to be a true vertigo. The symptom worsens on change of position, it's more again likely to be vertigo. But beware that symptom of dizziness occurring on getting up alone should not be counted as significant, since this can occur in postal hypotension, as you all know. True vertigo is always episodic. If somebody is telling you that I have got continuous vertigo throughout the day, it's unlikely to be a true vertigo. Of course, other symptoms like tinnitus, other neurological symptoms can help you differentiate vertigo from other causes of dizziness. Now, what are the common symptoms that can be confused with vertigo? The causes can be medical, neurological, or psychogenic. The medical causes, the most common one is orthostatic hypotension, which can be confused with the dizziness. Then hypoglycemic dizziness. The next common would be psychological conditions, like the feeling of floating, swimming, spinning inside the head, are complaint given by patients with panic attack, agoraphobia, OCD, etc. Among the neurological causes, the one which can be confused with the vertigo are double vision or postal imbalance. They may complain, they may come to you with complaint of dizziness. And the third most common condition is triple PD. This condition I will come to you later on. No, it's a common belief that an isolated vertigo is almost always due to peripheral labyrinthine problem. Is it true? No. Isolated vertigo can occur due to a brainstem infarct. A small infarct localized to the nodulus, root entry zone of the eighth nerve in the brainstem, or the vestibular nucleus can cause vertigo without other neurological symptoms and signs. One common vexing problem is that an elderly patient who comes to you with the emergency with an acute onset of severe vertigo imbalance, and we are at loss whether it's due to a benign condition like vestibular neuronitis or a sinister condition like vertebral stroke. How to differentiate in that situation? There are certain clues in the examination which help you to differentiate these two things. And it is the eye you have to look for and not the ear, even though the culprit is inside the ear. The first thing you look for is the nystagmus, the eye position, that is a skew deviation. Third is the head thrust. These are the three key tests by which you can differentiate the peripheral versus central. And of course, the gait and the targeted neurological examination. I'll come to this little later on. Now, coming to the nystagmus. The peripheral nystagmus or nystagmus due to a peripheral vestibular neuronitis is a side beating nystagmus, beats only to one direction, either to the left or to the right side. The nystagmus beats to either direction or it's a direction changing nystagmus, it is likely to be a central cause. Look at this patient's video. Look at the nystagmus in this patient. Here the nystagmus is beating to the right side. Even on looking to the left side, it is beating to the right side. And it becomes a little more prominent on the primary position and a little more prominent on the right. Between peripheral and central, avoid fixation. You can discover one and a patient cover the opposite time. In a sense, is blocked. You cover the opposite to the right. If there is diagnosis, there was avoid
Sarna, unmute you.
admit is some problem in between coming in and automatically get muted. Now the slide is not moving. Okay. Then the other thing is that diagnosis is so diagnosis factors like non-rapid nystagmus, we are not in nystagmus and central nystagmus.
Excuse me, sir. On the screen share you.
Okay. Am I audible to you?
Audible ആണ്.
Audible, okay. Other point we look is eye vision. That is, Q deviation means
സ്ക്രീൻ വന്നിട്ടില്ല സർ.
is down.
സ്ക്രീൻ വന്നിട്ടില്ല. സ്ക്രീൻ
You
ഷെയറിംഗ്
can see
ചെയ്തിട്ടാണ്.
right eye, left eye.
സാറിന്റെ വീഡിയോ ഡിസേബിൾ ചെയ്യാൻ പറയുമോ? ചിലപ്പോൾ കുറച്ചും കൂടി കണക്ടിവിറ്റി ബെറ്റർ ആവും.
I'll tell you. അവിടെ ഇത് ബാൻഡ് വിഡ്ത്ത് കുറവാന്ന് തോന്നുന്നു അവിടെ. സ്ക്രീൻ ഷെയർ ചെയ്യേ സാറേ. സ്ക്രീൻ ഷെയർ ചെയ്യേ.
Kumar.
സാറിൻ്റെ വീഡിയോ ഓഫ് ചെയ്തിട്ട് സ്ക്രീൻ ഷെയറിങ്ങിൽ ആയാൽ കുറച്ചും കൂടി ശരിയാവും.
And then what is take my friends and then okay, that's good.
ഹലോ ഹലോ അരുൺ.
ഹലോ. ജോയ് സാറേ, അതായത് മധുസാറിന് എന്താ അവിടെ ബാൻഡ് വിത്ത് പ്രശ്നമാണ്. നമുക്ക് അടുത്ത ടോക്ക് വെച്ചാലോ?
അടുത്ത ആളോട് വീഡിയോ ഓഫ് ചെയ്തിട്ടേ സംസാരിക്കാൻ പറഞ്ഞാൽ മതി. അപ്പോൾ കുറച്ച് വ്യത്യാസം വരും.
അത് സാറിന് മനസ്സിലായിട്ടെന്ന് തോന്നുന്നു. എനിക്ക് വന്ന് ഹരി റെഡി ആണെങ്കിൽ നമുക്ക് ഹരിയുടെ ടോക്ക് വെച്ചാലോ?
അത് വെക്കാം.
ഞാനൊന്ന് മറ്റേ റാമുമായിട്ടും സംസാരിക്കാമോ?
ആരായിട്ട്?
റാമോഹനുമായിട്ട്
സംസാരിക്കാം. ഓക്കെ.
ഹലോ.
ഹലോ ഡോക്ടർ മദൻ മോഹൻ സാറിന് ബാൻഡ് എഴുത്തിൻ്റെ പ്രോബ്ലമുള്ള കാരണം ഹി വിൽ ബി ലേറ്റ് ബൈ ഈസ് മൂവ് ടു അനദർ സ്റ്റേഷൻ. So to come back another 15 minutes it will take. In between, Dr. Ramkumar Menon will start his session. Dr. Ramkumar Menon, please. അത്രയുടെ ഹോസ്പിറ്റലിന്റെ പടം മാത്രമേ കാണുന്നുള്ളൂ കേട്ടോ.
Hello. Kekanda.
കേൾക്കാം കേൾക്കാം കേൾക്കാം.
Okay. So can I start then?
Okay, you can start.
Good evening, everybody. And I'm Dr. Ramkumar from Atreya Hospital. I'm the consultant neurosurgeon there. And first of all, let me thank the IMA to have allowed us to speak here and on the specific topic of headache, which is such a common entity. I would like to especially thank Dr. Joy, the president, Dr. Pawan, the secretary, and Dr. Santosh Babu, who have actually taken the initiative to have this session on and permit us to go ahead and present. Unfortunately, due to some pressing issues related to the range, Professor Madhu's session had to be postponed, and he said he'll be joining in a very short time. So I'm here to just fill the gap. And meanwhile, Dr. Haridas will be also here, and he will be talking on the medical part of it. I'm here only to speak on the surgical related issues. So probably people who look at it might find some discontinuity because the surgical issue is being dealt first, but we'll have a detailed lecture with Dr. Hari. So let me start on.
Before starting, Dr. Ramkumar, let me have an introduction of yourself.
All right, okay.
Dr. Ramkumar Menon MCH FSCH. He did his MCH neurosurgery from MCH Calicut, neurosurgery training from King Edward Hospital, Mumbai, fellowship training in skull-based surgery from Slovenia Baron Neurological Institute, Arizona, consultant and HOD neurosurgery, Atreya Hospital, Thrissur, experience over 18 years in neurosurgery, successfully performed over more than 3,000 surgeries, only Indian and second Asian selected, robot S chamber link fellowship for spine biomechanics, over 25 publications. holding patent for innovative neurosurgery devices. He has been keen interest in spinal surgeries, especially special interest in minimal access disc surgery and cervical arthroplasty. Craniovertebral junction is his another area of interest. His hospital today, Atreya, is the MD of Atreya Medical Speciality Hospital, and they are, complementing this scientific session. And I thank you, Dr. Ramkumar Menon, for your compliments, and I welcome you for this session as the faculty, and to continue handing out to you, sir. Thank you.
Thank you very much, sir. With permission of Professor Andrews, sir, may I go ahead? Hello?
Please go ahead.
Okay. Right, thank you. So what I'm going to be talking is a very brief discussion, and this is essentially I'm going to be talking only on the surgical aspects. So let me go ahead. There are some very, very common conditions that we encounter, especially from the surgical perspective, because most of these headaches are being dealt with the neurologist. So the neurologist primarily sees this patient and they evaluate, and then when there is a surgical entity involved, they refer it to us for further management. So what are these entities that we usually encounter? I'm going to talk of some of the common conditions, because I've been given the topic of red flag signs in headache management from the neurosurgeon's desk, and where that essentially would imply an acute onset headache. And I will come on to that topic a little later, but let me start off with these. So we were talking of essentially IIH, the idiopathic intracranial hypertension, and then CSF leaks, the subarachnoid hemorrhage, which is one of the surgical causes of severe acute onset severe headache. And of course, we get to see a lot of patients with brain tumors or space occupying lesions who present with headache. I'll briefly go through this because IIH is a topic which overlaps with the neurologist and the ophthalmologist. CSF leaks, it overlaps with the ENT surgeon, because we work in tandem with them to deal with these leaks. And of course, subarachnoid hemorrhage is dealt by us, and brain tumors are dealt by us. So idiopathic intracranial hypertension, what is the neurosurgeon's role? What exactly is the neurosurgeon's role? So we come in when it has to be surgically treated, and the behavior of the idiopathic intracranial hypertension is no longer benign. So we need to identify the etiology, and we need to see if that is a surgically treatable disease, and that is when we come in. So patients usually present with a lot of visual symptoms, and they have worsening vision. Papilledema is getting worse, so you usually have the ophthalmologist refer it to the neurologist, or the neurologist refer it to you. So what are the indications for surgery in idiopathic intracranial hypertension? It's usually a new or worsening field defect, or there's a reduction in the visual acuity, or the patient has persistent headache which is non-responsive to medication. When they say medication, usually they give acetazolamide, or in severe cases where they give in steroids. And what are the surgical options that are available for treating idiopathic intracranial hypertension? There are some of these surgical options that is available currently now, which is one of this would be optic nerve sheath fenestration. And the other option would be a lumboperitoneal shunt, or what we call a thecoperitoneal shunt. All of us are aware about the ventriculoperitoneal shunts, and of late with the interventional neurology coming into the picture, dural venous stenting is started to play a big role. And of course, IIH, one of the etiologies being obesity, especially in females of the reproductive age group or the younger females, bariatric surgery has a role. So optic nerve sheath fenestration, lumboperitoneal shunt, ventriculoperitoneal shunt, and dural venous stenting is actually in the armamentarium of the neurosurgeon. In optic nerve fenestration, what we do is we expose the optic nerve just behind the globe, and then you make multiple fenestrations onto the dural sheath so that the CSF egresses into the orbital fat, and it reduces the stasis that happens because of the block in the axoplasmic flow. And that CSF gets absorbed into the venous circulation, and that is one of the techniques wherein you salvage the vision of the patient. There are the CSF diversions that I spoke about, like the lumboperitoneal shunt or the thecoperitoneal shunt or the ventriculoperitoneal shunt. In the lumboperitoneal shunt, what happens is we put in a shunt through the back, and we introduce it into the subarachnoid space and allow the CSF to drain from there into the peritoneum. But the problem with the lumboperitoneal or the thecoperitoneal shunt is at the end of 1 year, the failure rates are slightly on the higher side. So a ventriculoperitoneal shunt, which is very commonly performed surgery in neurosurgery, would be a better option when you look at the outcomes. And what is with intracranial venous sinus stenting? When you have a diffuse disease, it's not easy to stent the sinuses. If you have a focal venous sinus stenosis, it is the right indication for stenting the sinus, and usually we put an expandable or an endovascular stent into that area. And nowadays we get a lot of malleable stents, so it can actually negotiate and navigate the different tortuosity or the curves. What happens to the visual outcomes when we intervene with these patients? We have found that the vision actually improves, because the difference between an idiopathic intracranial hypertension and what you call a malignant changes is just that the vision, the loss of vision, is responsible for the morbidity of the disease. So salvaging the vision is our first priority. And this meta-analysis has revealed that, sorry, it's gone back. It has revealed that visual defects usually improve. And when you do ventriculoperitoneal shunt, again, there's an improvement in the vision of the patient. But the problem that we face is convincing these patients, especially being young females, to undergo a procedure like a VP shunt or a lumboperitoneal shunt. The next commonest thing that would happen is CSF leak. And CSF leak causes low pressure headache in patients. And we work in tandem with the ENT surgeon, and Dr. Arun is here today, so he will also be probably talking on the same. I'll just briefly run through the surgical side of the CSF leak. What kind of leaks do we encounter actually? We encounter high pressure leaks as in when there is a concomitant hydrocephalus. And one of the commonest area where we see these high pressure leaks are in the anterior skull base, which is actually in the cribriform plate area. So whenever there is an area of when there is evidence of raised pressure, it usually, the cribriform plate being one of the thinnest area, acts as a safety valve, and it just breaks down, and you have the CSF leak coming through the nose, and usually they present with CSF rhinorrhea. And this is commonly associated with slow growing tumors. And it's not necessary that these tumors are located in the frontal area itself. We have had patients who we have seen with the meningiomas, slow growing meningiomas, which are located in the torcular area, in the occipital area, and the tumors have achieved massive size, and it has been exerting a pressure, and CSF rhinorrhea is the first presentation rather than a headache. And these patients come with rhinorrhea, and you investigate, and retrospectively find large tumors or large lesions. So again, when they have these leaks, they present with what we call low pressure headaches, and then that has to be surgically treated. We can have normal pressure leaks again through the cribriform plate area, but even osteomyelitis of the skull or any other persistence of any of the congenital defects can cause these CSF leaks, and which can cause headache. What about spontaneous CSF rhinorrhea? Spontaneous CSF rhinorrhea per se is extremely rare, and usually there is a history of trauma, and it is at that time that they present with CSF leak and headache. So this slide just elicits the causes of headache, which is actually an increased ICP, which I discussed about, or in, as I said, the normal pressure with the patient with a normal ICP. There are these pulsations along the skull base, and these pulsations gradually erode the cribriform plate, and they can present with CSF leak and a low pressure headache. Or if you have the sinuses, which are extremely pneumatized, again, they can present with CSF leak. So we usually detect them by using something called a CT cystonogram, or we use a special sequence in the MRI called a heavy T2 weighted MRI sequence. If you look at this slide, you can see that there is an area of defect there, and you can see the CSF leak that is happening through this area. And that is actually the area of the cribriform plate. Again, the treatment would be medical and surgical. So the role of neurosurgeon is when to intervene. The surgical indication, the surgical approaches are done in basically two ways. One is the endoscopic endonasal surgery, wherein we work through the nose in tandem with the ENT surgeon. The ENT surgeon is more familiar with the topography of the nose, and they help us and they guide us to the skull base, from where usually the neurosurgeon takes over and we perform the endoscopic repair. Or the next option would be an open surgical repair. And usually these are only, we only intervene after we have attempted a period of conservative management, or this patient keeps continuing, he has a leak and then he stops, the leak doesn't happen, and then he comes back with the leak. Sometimes the gap between the leaks is over months, maybe 6 months, or they have high pressure leaks, which we know will not resolve with conservative line of management, as I said, with the large brain tumors. And when they have these brain tumors, they have to be tackled in first, and then the leak has to be taken care of. Or these patients have recurrent meningitis, or they have an associated congenital anomaly, or where there is a destructive lesion. The primary thing, or the most important thing here, would be to localize the defect and go ahead and correct it. I'm not going into the surgical nuances of the technique. Well, the aim is to essentially create a plug, and you can plug it outside the dura or inside the dura. And the approaches for an open surgery would be a transcranial approach, where we do a bifrontal craniotomy and we put a graft and we try to plug the area. Nowadays, we get a lot of other substitutes other than the normal graft, and we use them to plug those areas. So the subarachnoid hemorrhage, this is one of the commonest cause of an acute onset headache, and actually the title, which says red flag in headache, this is one particular entity which actually is of grave concern to the neurosurgeon. Patients come absolutely fine with no antecedent history of headache, and then they just, they experience a severe headache, which may last for a few minutes, a few hours, or it may last and it keeps worsening over a period of time. So when they present to the casualty, usually we do a CT and we find that there is a the streaks of blood which goes along the different cisternal spaces, as you see here, the white color which spreads along the interhemispheric fissure and along the sylvian fissure, or sometimes they have massive SH which actually extends all along the cisterns in different areas of the brain. That is when actually we come into play. So depending on the consciousness of the patient or the scoring of the patient, what we do is, if needed, we ventilate them, and then we immediately take these patients for an investigative modality. And we usually perform a CT or a CT angio, and we identify the aneurysm. As you can see in this slide, aneurysms located in any part of the brain can present with SH in any part of the brain, but usually the vessel which is nearest to the cisternal space usually shows evidence of dense bleed, and that presents as an SH. Some things of concern to us is, as you see in this slide, if you see the one, this slide, the first and the last portion, you can see a large basilar top aneurysm. So what concerns us is, are these aneurysms surgically manageable or they require an intervention? The choice is actually very variable. We have seen a spurt of endovascular treatment happening in the last decade, but having analyzed the results of these endovascular stenting, I think now we're a little more wiser to understand the option that we have with us, because some of these aneurysms are best treated surgically and some of them are best treated using endovascular techniques. So just for everybody to understand what actually happens, when we do surgery, we clip the aneurysm. So if you see the vessel here and you see this nubbin there like that, so we put a clip across and we close the aneurysm. So that way we prevent the blood getting into the aneurysm and the aneurysm to progress. So that is the surgical clipping. And sometimes it is not possible to clip the aneurysm. And so what we do is we actually we close the vessel. We close the vessels on both ends, and then we perform a bypass surgery so that the blood flow from the proximal to the distal part. So if you have an aneurysm which involves this part of the vessel, essentially if we make sure that we ensure that we don't sacrifice any of the major vessels, and then we trap them. What we call is trap them. We close them here, and then we perform a bypass like that. So the blood flow is obtained from the proximal to the distal end. And as I mentioned about the next option, which is the minimal invasive technique, is coiling, wherein platinum coils are inserted using a transfemoral technique access, and then they are used to coil these nubbins, and sometimes we require protection like stent guidance or a flow diverter to secure them. So this is my operating room, and we are the new kid in the block. We just opened a few days back, and we have been successfully performing some of these surgeries. Just to show you some of these patients who had presented with almost all of them. I mean, almost all of them have presented with headaches and aneurysms, and they have been operated. Some of them do present with cranial nerve deficit, as you can see in the second one, where this patient has presented with ophthalmoplegia, and post-surgery the ophthalmoplegia persisted. The next commonest thing that we encounter, or that as neurosurgeons we get referral, is for intracranial space occupying lesions. And incidentally, these patients have headache. They go to a neurologist or they go to a practitioner or a physician, and CT scan is done. And sometimes, surprisingly, we find large lesions which have grown to huge sizes. And that is the reason when they come to us and we go ahead and operate them. If you look at this, we can see these this large frontal meningioma, and this patient again had presented to us with headache, and then I had gone and operated these patients. It's just a series of slides to show you the different locations of this meningioma. This is in the front, this is on the temporal. Again, these patients with cavernous sinus or a large CP angle tumors which present with headaches. This one of the classical patients with a large olfactory groove meningioma who presented with intense headache. And of course, it all depends on the tolerance level of the patient as to how much of it, because usually these are not this acute bursting kind of headache, unlike a subarachnoid hemorrhage where they warrant an immediate attention and they come to the casualty. And as I said, they usually meet with their practitioners, or they meet with their physicians or neurologists, and then they are usually referred to us for management of these headaches. Sometimes we have these non-malignant or cystic lesions like a large arachnoid cyst, which is usually a congenital deformity, and then we go ahead and operate these patients. And these are all basically surgically manageable causes of headache. So this is our rehab space where we rehabilitate these patients following surgery, following whatever kind of major procedures that we do. So let me again thank the IMA and thank all the speakers who have actually agreed to come here and present this. Let me specifically thank Madhu sir and Dr. Haridas, Dr. Rani Menon, and Dr. Arun, who are the co-speakers. And I hope by this time, Dr. Haridas would be ready for his presentation and Dr. Madhu would be able to join in soon. Thank you, Andrew sir. Thank you very much for this time.
Thank you, Dr. Ramon, for the excellent presentation. I think we will have the questions and discussion at the end of the session. If Dr. Hari or Dr. Madhu sir is ready, we can go. Madhu sir, please.
Yeah, come back.
Yes. Right.
Am I audible to you?
Yes, sir. We are audible, sir.
Ramkumar Menon, please.
Yeah, right.
Disable your screen sharing. Okay, thank you.
Shall I start?
Screen sharing.
Okay.
സാറ് സംസാരിക്കുമ്പോൾ സാറിൻ്റെ വീഡിയോ ഓഫ് ചെയ്തേക്കട്ടെ, അപ്പോൾ കുറെ കൂടി ബാൻഡ് കൊടുത്ത് കിട്ടും.
ഓക്കെ റൈറ്റ്. ഇടയ്ക്ക് ഇതിന് വീഡിയോ ക്ലിപ്സ് ഉണ്ട്, അതുകൊണ്ടാണ്. ഓക്കെ,
അല്ല വീഡിയോ ക്ലിപ്സ് ഇട്ടോളൂ, യുവർ വീഡിയോ, സംസാരിക്കുന്ന വീഡിയോ.
Start from the very beginning or
you can start from the very beginning. We had a big interest.
Yeah, right. I'm going to discuss with you 4 problems. One common problem faced by every physician is the dizziness and vertigo. Many patients come to the so-called vertigo as an isolated symptom, where at times at a loss to differentiate whether it's true vertigo or not. In that situation, what question would you like to ask to clarify the issue? As already told, talarakam is that term which has been often misused in neurology. For the patient, each and everything is talarakam. So, for example, it's just heaviness of head, feeling of imbalance, unsteadiness, blurring of vision, diploma, they all come in the same complaint of talarakam. So it's our duty to differentiate whether it's a true vertigo or some kind of a non-vestibular dizziness. The description of symptoms can give a clue to differentiate the two. For example, sensation of spinning, sensation of feeling drunk, sensation of motion sickness, feeling of falling to one side are symptoms which are suggestive of. On the other hand, spinning sensation inside the head, floating sensation, swimming sensation, and feeling of near painless are symptoms suggestive of non-vestibular dizziness. Some people may not give a true history of a spinning sensation, even though they have true vertigo. In that case, it's like a non-specific dizziness. There are 2-3 points we can make in differentiating to true vertigo or not. If that particular symptom is associated with vomiting or autonomic phenomena like sweating, that symptom is more likely to be vertigo.
I'm just saying.
Similarly, the symptom worsening with position change is again more likely to be true vertigo. Beware that postural hypotension also can produce that worsening of the symptom on getting up from lying down position. True vertigo is almost always episodic. Somebody telling you that I got constant vertigo in day and in out, that's unlikely to be a true vertigo. And of course, other symptomatologies like tinnitus and neurological symptoms can help to diagnose the symptom to be true vertigo. What are the common symptoms which can be confused with vertigo? The symptoms can be medical, neurological, or psychogenic. The medical causes which can be confused with vertigo are the most common one is the orthostatic hypotension. And second is hypoglycemic dizziness. And next common would be a psychological conditions. For example, these people give the complaint of floating, swimming, or spinning inside the head. This can be seen in many psychiatric disorders like panic attacks, agoraphobia, obsessive compulsive disorder, etc. And with the neurological causes, the person you should clarify whether the dizziness is actually what the patient needs is double vision, or imbalance to defective proprioception, or a postural imbalance. Other conditions, triple PD, that I will come little later on. Now, it's a common belief that an isolated vertigo is almost always due to peripheral labyrinthine problem. Is it true? No. Isolated vertigo can also occur due to brainstem infarct. A small infarct localized to the nodulus root entry zone, the 8th nerve in the brainstem, or the vestibular nucleus can cause vertigo without other neurological symptoms and signs. Important vexing problem is the casualty is an elderly patient who comes to you with vertigo and imbalance with no other symptomatology. It's difficult and we are at a loss to differentiate whether it's a benign condition like a Western neuronitis or a sinister condition like a beginning of a vertebral basilar stroke. In that case, how to differentiate? Mind you that it is the eye you have to look for and not the ear. There are three things you have to look for. One is the nystagmus. Second is the eye position. That is a skew deviation. Third is the head thrust test. And of course, gait and target examination also can help differentiate. Now, if you look at the nystagmus due to a peripheral problem is side beating or beating to direction fixer. It beats only to one direction, either to the left or to the right. On the other hand, a central nystagmus is more likely to be direction changing. That means it beats to the left when the patient beats to the left side, beats to the right side when the patient beats to the right side. For example, look at this patient's video. You can see the nystagmus beating to the right side. When you look to the left side, it beats to the right side. And bringing back to the primary position again, beating to the right side. Again, beating to the right side. Looking to the right also, it's beating to the right. So that means it's a direction fixed. The other point by which you can differentiate is that find out whether the nystagmus is increased by avoiding fixation. How to avoid fixation is a simple bedside technique is that you view the eye through the ophthalmoscope. You can look at the optic disc. You can find out that the movement of the nystagmus can be seen in the movement of the optic disc. When you move the ophthalmoscope through one, this is ophthalmoscope, the contact eye. That is essentially the nystagmus increase is there is a peripheral cause. Let's look at this picture. Here it is beating to one side, but it's accentuated when fixation is removed. That means it's likely to be peripheral nystagmus. On the other hand, central nystagmus does not get modified by avoiding fixation, remains the same. The other type of certain other types of nystagmus also favor central lesion, for example, gaze-walk nystagmus. Pure nystagmus vectors, for example, pure vertical nystagmus or pure rotary nystagmus, are nystagmus which are not seen in peripheral lesion, are seen in central lesions. The other clue to differentiate between peripheral and central is eye position. That is a skew deviation. Skew means one eye is up, one eye is down. For example, in this picture, you can see that the right eye is up, left eye is down. We find such a vertical separation likely to be. A subtle vertical separation will be difficult to see on just by looking at it. In that case, what you can do is you do an alternate cover test. You cover one eye, then shift the cover to the other side. Then you find that the vertical up and down movement of the eye will tell you that there is a small vertical deviation was existing previously. The third thing and most important thing is the head impulse test. Head impulse test is based on what is called the vestibular ocular reflex. There's nothing great about it. This reflex is the one which maintains the image of the retina of the fovea, irrespective of head motion. Suppose you were looking at an object. In whichever direction you move the head, the image will still the image will not move. It will still be able to focus on the image. This is made possible by what is called the vestibular ocular reflex. Look at this picture here. When you move the head towards the left side, as you can hear, the left horizontal canal is activated, lateral is activated. It makes eyeball movement to the equally to the opposite side. So the eye remains on the target. So you don't get a blurring and the eye remains on the target. On the other hand, imagine that the left lateral is defective or affected. When you turn the head to the left side, eyes moves along with the head. It will not remain on the initial target. So what will happen? It moves along with the head. So you make a corrective saccade back to the target. There is a catch-up saccade. If you see a catch-up saccade, that means that lateral is affected. For example, look at this patient's, I'm doing the head thrust. There is quick movement to either direction. for about 20 degrees. See, on looking to that, turning the head, you can see the corrective saccade back to the right. On the other hand, turning to the right side, there is no corrective saccade. Turning the left side again, you can see the corrective saccade. So that means that on turning the head to the left side, that corrective saccade is appearing, meaning left side is at point. So these three things, that is the type of nystagmus, the Edinburgh's test, and the skew deviation, can largely differentiate a peripheral from central lesion without any neuroimaging. So a positive Edinburgh's test favors peripheral, but rarely may occur with vestibular root and zone lesion. But a negative Edinburgh's test favors a central lesion in a person with vertigo and nystagmus. The type of nystagmus, I already told you how to differentiate between the two. And presence of skew deviation, if it present, it says recessive of central lesion. But again, one caveat is that absence of skew may occur sometimes in peripheral or with central lesion. So that in absence of skew may not help, but presence of skew will tell you likely to be central. So to call a peripheral lesion, all the three things should be favoring peripheral. For example, Edinburgh's should be abnormal, nystagmus should be unidirectional, and skew should be absent. If any one of them is favoring a central lesion, think of a central lesion. So sometimes what happens is that in practice, in practical situation, the patients come to emergency with vertigo and vomiting. He may not allow you to do the head thrust test. He may be distressed because of the vertigo and vomiting. So you can rely on this test on 100%. In that case, can we do an MRI to differentiate? The initial diffusion weighted MRI may be falsely negative in 12 to 20% of stroke patients during the first 48 hours. That means you may miss even a stroke with MRI. So these tests can differentiate. So if the patient is not cooperative enough, look at two other clues, what you call hints plus. That is adding another bedside test that is looking for the associated hearing loss. So we have been taught from the basic, from our school days, that from previous days, that when you get vertigo and deafness, think of a peripheral. But it is not true, because so-called acute labyrinthitis affecting both cochlea and the vestibular division is quite uncommon. Most of the time it is acute vestibular neuritis. If you think that with vertigo, it is more likely to be central. Because the blood supply to the both structures is 90 in inferior cerebral artery, so you get a deafness associated with vertigo more likely to be a central rather than a peripheral. Another clue at the bedside is looking for balance. In general, patients with unilateral peripheral vestibular loss can maintain balance even when the vertigo is very severe. In contrast, severe imbalance that impairs sitting or standing usually indicates central vertigo. Somebody is coming vertigo and two persons are holding him, and when you get this, you're considering to think that it is central and not peripheral. But at this point, already said. Another problem vertigo, the patient becomes episodic vertigo. He had one study had vertigo lasting for 3-4 hours, 3 months back, another episode, and then comes to you. What conditions cause this type of presentation, and how to differentiate these conditions clinically? The two most important conditions here are the Meniere's disease and the vestibular neck pain. Rarely, vestibular TAA can be recurrent, but more often when it is recurrent, they can associate symptoms. And non-vestibular diseases like panic attack, etc. Now, if you get a person coming with episodic vertigo, the one question you have to ask is that what is the duration of each episode? For example, if it is a very short, a fraction of a second vertigo, it's not a vertigo. It is most likely a phobic vertigo or so-called triple PDA from later on, not a true vertigo at all. On the other hand, the duration is 5 to 90 seconds. It is brain paroxysmal vertigo. If it is 90 seconds to 20 minutes, think of TAA or migraine. The sinister condition of TAA come under this duration. If the duration is more than between 20 minutes and 24 hours, TAA is another possibility, but many also comes the diagnosis If it's more than 24 hours, think of vestibular neuronitis or a CNS disease. In the episodic vertigo of 3-4 hours duration, the two important conditions are included vestibular migraine mini disease, and vestibular migraine is the most common cause of recurrent spontaneous vertigo. What are the features? While vestibular migraine can develop at any age, it generally affects persons with long established history of migraine. Vertigo attacks can alternate migraine headache symptoms. And vertigo can present as spontaneous vertigo, positional vertigo, or even motion intolerance. Attack duration can vary from minutes to days. Headache may begin before, during, or after the dizziness. Sometimes it may be totally absent during the attack. So in that situation, associated migraine phenomena, like for example, phonophobia, photophobia, osmophobia, visual auras, accompanying the visual migraine, if present, that can help you diagnose, but sometimes this may not be there. On the other hand, Meniere's disease is relatively uncommon cause of dizziness. Patient classically presented with episodic vertigo accompanied by unilateral tinnitus and awfulness, often with reversible sensory hearing loss. Episodes typically last minutes to hours. Now, sometimes it's simply difficult to differentiate between the two because at an early stage of the disease, it may be difficult to differentiate Meniere's from vestibular migraine because the oral symptoms like tinnitus and deafness may not be present in the Meniere's disease. So in that case, how differentiate? A history of repeated recurrence over years without permanent sequelae favors vestibular migraine. Even if they don't have any headache, they don't have any photophobia, episodic attack, long duration without any deafness, migraine. On the other hand, continuous tinnitus and persistent deafness are features more favoring Meniere's disease. The most labeled differentiating feature is the low frequency hearing loss in Meniere's disease. Now, another problem is that, say, patient coming to you with that story of a patient, he comes to you with a fall from the bike. Next day morning, when he got from sleep, he had severe spinning sensation, which subsided lying down again. After some time, the same thing recurred when he bent down to take water. So, what is the problem with him? This is benign cross-positional vertigo. This is the most common vertigo, and incident it increases with advancing age. So it's triggered by change of head position with respect to gravity. So the complaint of the patient will be dizziness or getting up from or turning in the bed or bending down for times 2 days or looking at the ceiling. But here you are differentiate between a positional vertigo and a positioning vertigo. For example, any vertigo can be worsened by change of position. That is called positioning vertigo. That is not sensitive to BPPV. Vertigo is triggered, precipitated by change of position. Then you think of positional vertigo and BPPV. It can be peripheral and peripheral cause of BPPV. There are two common types. But the posterior BPPV that is the most common. Second is the horizontal BPPV. The basic problem is that calcium particles between the autoconjugate get dislodged and fall in the vesicular canal and then become stimulated unwantedly unnecessarily. How to diagnose posterior BPP with a Dick's Ortex maneuver? There, what you do is that turn the head 45 degrees to one side and bringing down like this. I'll show the video, then it'll be easy to understand.
45-degree angle to the right to test with
and bring it down like that and look for the nystagmus. And what we look for nystagmus, which beats and rotates the same side. This is the posterior canal. Here is occur after latent period of 1 to 2 seconds. It's a mixed vertical and dorsal nystagmus. Nystagmus increases and for 10 seconds in fatigue. When the patient sits up, there is recurrence of nystagmus in the opposite direction. The horizontal canal BPPV is what is called supine roll test. You roll the head onto the left and then to the right side. Then you can find out the appearance of horizontal nystagmus. Like this.
The head is turned quickly to one side. One looks for nystagmus.
Turn to for 20 seconds, look at the nystagmus, bring back to the primary position, and turn back to the left side.
And then the same thing is done.
Again, you can nystagmus appearing. So look at this particular video. This patient is like so fine. There is nothing is happening in the eye. Now I'm asking you to turn to the left side. He's turning to the left side. You find the nystagmus now when beating to the left. That is beating towards the left means he's lying on the left side, beating to the ground. That is towards the left side. After some day, the nystagmus become less and bring the patient back to the primary position. There's no nystagmus now. Now I am turning the head to the right side. No nystagmus. Now turning the right side. Now the nystagmus is to the right. Then here it is much more larger amplitude. That means the affected ear is the right side. So this is what is called the geotropic type of nystagmus. That is, in whichever direction turn the head, the direction the first component is to that direction. Now, most of the causes are idiopathic. Sometimes it can follow head trauma, otitis media, etc. Now, rarely, positional vertigo can also occur due to central lesions. The lesions in the fourth ventricle affect the vestibular nuclei or the cerebellar neurons. The causes can be multiple sclerosis, cerebellar neurons, and malformation. Now, how to differentiate between the central and peripheral? 95% most of the time it is peripheral. The type of nystagmus in posterior BPPV, you find that nystagmus is vertical and torsional, upbeat and torsional. On the other hand, pure nystagmus, pure vertical nystagmus, or pure horizontal nystagmus, you think of a central lesion. In peripheral, when you change the head position, the nystagmus and vertigo will not appear immediately, as latently, also few seconds. It occurs immediately on changing the position, I think it's a central lesion. You keep the head in the same position, it subsides in the case of peripheral, whereas continue to occur in the case of peripheral. If you bring the head repeatedly in the same position, the peripheral nystagmus and vertigo subsides. On the other hand, central will continue to occur. Now, this is a very common problem, is often underdiagnosed and missed by many people. But it's a patient complains of continuous vertigo and dizziness. He always carries a cane for the fear of fall. What do you think of this condition? If somebody complains that he's having continuous vertigo, it means that he's not having vertigo. Most likely, it is triple P. Triple PD means persistent postural perceptual dizziness. This is a new term for your previous phobic postural vertigo and chronic subjective dizziness. Who do you suspect? Somebody sitting in front of you, the consultant holding on his chair tightly. That's unlikely for that patient, otherwise no complaint, think of triple PD. Or patient walks with a cane or a walking stick all the time, but otherwise he walking is normal, think of triple PD. These patients walk very cautiously without any finding of neural examination. Now the usual story of these patients are like this. They say, I feel as if my body is swaying like I'm on a boat. I feel I'm about to fall. I feel as if I may pass out, I may fall unconscious. I feel spaced out as if my legs are spongy or as if floating. This kind of symptomatology are the one with the patient complaints in the case of triple PD. In fact, remember that is the second most common cause of dizziness is triple PD. Now, this is a chronic functional disorder of nervous system, known characterized by not spinning vertigo and perceived unsteadiness. The symptoms may wax and wane, and the symptoms are excited with three factors. They don't have this kind of phenomenon when sitting or lying, only on upright posture. During active or passive motion, and exposure to moving visual stimuli or complex visual patterns in crowded places. For example, these people are very uncomfortable. They cannot walk on the carpeted floor like this. Or in the crowded place also, they find it very uncomfortable to walk about. And what usually happens is that a person develops an acute vertigo due to real visual neuronitis. Patient improves, but he comes to say, my vertigo is not over. I'm always unsteady. I'm always having kapalaga. But in that case, what most of the time is having is that triple PD, because this persistent perceptual dizziness is precipitated by an acute event like acute visual neuronitis. Then, as a physician, we must know when do we do neuroimaging in the suspected vertigo. As told before, fatigue with profound imbalance, fatigue with focal deficits, with new onset headache, the type of nystagmus or direction changing, or pure nystagmus fatigue, the vectors to think of you need to do neuro. Now I'll come to the second common problem faced by physicians in their day-to-day practice. A person comes to you with transient loss of consciousness. For example, it's a common situation. A 60-year-old man, while coming back from the bathroom, fell unconscious and got up by himself. He did not have any premonitory symptom and did not know how he fell. And following recovery, he did not have any complaints. And he comes to you on the next day, so what did they have? So, transient loss of consciousness is defined as an apparent loss of consciousness with rapid onset, short duration, spontaneous, and complete recovery. The causes can be traumatic and non-traumatic. Traumatic, we know it's easy to diagnose. Non-traumatic, the most common is a syncope, seizure, metabolic disease like hypoglycemic episodes, hypoxia, and hyperventilation with hypocapnia, heterocephalic attacks, or raised data intention, and this is another very rarely, but a brevis. Now, syncope is all identified by decreased cerebral perfusion. The only difference between syncope and sudden death is that in one you wake up, in the other you don't wake up. Now, if somebody comes to you with syncope, what are the causes? There are 5 important categories you have to keep in mind. The most common is a neurally mediated. That is a classical vasovagal syncope, carotid sinus sensitivity, situational cough, and post-micturition. These constitute 66%. Second is a cardiac apnea, radius sinus syndrome, maybe block, non-QT syndrome. This constitutes about 11%. Orthostatic is another one. This I want to remind you that many persons we are missing orthostatic hypotension because the patient may having the same elderly having the same this. Many of them have prostatic problem. They may be on alpha blockers. If you remove the alpha blocker, the patient orthostatic hypotension disappear. They will not fall. And when you do the postural testing, the BP fall may not be there when you examine, but at another time it may be there. Some people have a postural hypotension called prolonged postural hypotension. This constitutes the 10%. Then structural cardiopulmonary, it is easy because the cardiologist will pick it up. Aortic stenosis in HOCM and pulmonary hypertension. And non-syncope comes from the seizure problem and psychotic. These are the 2 common things you have to keep here. Then in 2%, we do not know the cause at all. The vasovagal syncope, you all know, I think I will skip that thing. They provide emotional pain. They can be okay. The point to remember is that in reflex syncope, there is bradycardia as well as hypotension. In the case, the other cause of syncope is situational syncope. Then reflex syncope with some specific circumstances like post-exercise syncope can occur young athletes as a form of reflex syncope. Then during mixture, you all know cough syncope can occur. Long bout of a cough can make syncope. Sometimes straining its tooth can produce syncope. Sometimes solo syncope can also. Now, how do you produce? The third thing is the orthostatic hypotension. It may be problem with the sensor. There is aortic, carotid bodies, cardiopulmonary barrel receptor dysfunction. For hypovolemia, you are bleeding somewhere can produce hypertension. And of course, the effective problem like sympathetic nervous system dysfunction, either due to your drugs or due to your diseases causing autonomic dysfunction. So always ask about other autonomic dysfunctions like cardiac sweating, dry mouth, nocturnal diarrhea, urinary frequency, impotence, ejaculation. This will say like your problem, that it's also syncope, like postural hypotension. Now, how do you approach a patient that turns across the consciousness? This is a common thing. Patient comes to the neurologist, he finds nothing on examination, he takes an EEG, finds nothing. Then he is quite somewhere to shift the patient to the cardiologist. The patient goes to the cardiologist, takes an ECG, and then appropriately takes a postural hypotension, find nothing, then shift the patient to the neurologist. Ultimately, the patient goes with the diagnosis. So, how to go about initial diagnosis, examination, details, examination, BP, ECG, monitoring. Okay, this will forget about it. Now, The clue is the history. That is the most important thing. You are asked about the time of occurrence, what was it doing when the event occurred, in associated voluntary movement, any parallel cyanosis and post-ictal phenomena, or premonitory symptoms. What are the pointers in the history by which you can arrive at your diagnosis? The thing you are asked is the onset and the setting in which it's occurred. If the onset is very abrupt or sudden, it's likely to be cardiac or seizure. If it is arising from sitting in a position, you know it's supposed to be hypotension. If it is occurring varying duration after standing for some time, it may be vasovagal time. The setting is important. If it's syncope is occurring during exertion, like playing or climbing up stairs, it's likely to be a cardiac obstruction, or subclavian syndrome, etc. Or specific triggers, for example, the patient has got shaving and head tilt, carotid sensitivity, or in a perspective like micturition, cough notification, you can influence situations. Historical pointers are episodes occurring with arm exercise, subclavian steel aortic dissection, syncope occurring with changes in position, sitting to lying or bending and turning in bed. It creates the possibility of atrial myxoma or a thrombus. Syncope occurring access to already told aortic stenosis and pulmonary hypertension. Family history of sudden death, long QT syndrome, brief loss of consciousness with no prodrome and has heart disease, arrhythmia, frequent syncope with no symptoms but no heart disease, most likely psychogenic. So these are the medication releases, endless many drugs can cause. Go through a medication release that may be the culprit of causing this episodic loss of consciousness. The other important condition is the seizure you have to differentiate. Suppose there may not be an eyewitness episode, very difficult sometimes with an eyewitness diagnosis seizure. The one clue is that ask specifically for the presence of cough. If loss of consciousness preceded by an aura, the patient saying that raise epigastric sensation, altered taste or smell, or deja vu phenomenon, Jacksonian mark, that thing will tell you that means a symptom suggestive of a focal cerebral irritation. That means it's a seizure. If the aura is not there, we are often at a loss whether it's a seizure or not. Similarly, some premonitory symptoms for syncope, different thinking, lightheadedness, loss of color vision or graying of vision, sounds seem to come from far away. These are symptoms combined with syncope. Of course, preceding nausea, fatigue with chest pain, palpitation, etc. And even during syncope is important. Syncope, the patient is flaccid, eyes are usually open or straight upward. Jacks with limbs can occur in syncope also, but these jacks last only a few seconds and a small amplitude and not rhythmic for single. Incontinence can occur in syncope as 25%. Tongue bite is rare. Unconscious usually lasts less than 20 seconds syncope, but a prolonged loss of consciousness, things likely to be more like a seizure. Post-event, falling and lying down usually helps to restore the consciousness, syncope as you all know. But a post-ictal confusion and post-ictal headache more often points to a seizure. Similarly, post-event mood changes such as seizure disorder. And psychogenic epilepsies, the patient's eyes remain closed, that never occurs. Recovery can be slow and weeping may that can be provoked by heat. Now, having finished the second common symptomatology, the other problem the patient comes to you with episodic weakness. This is a common, it's a call from the specialty often. The house surgeon calls you, sir, I have a patient in the casualty who is weak. Shall I order an MRI or a CT for the brain? If I ask you what is the most expensive tool as a physician, this is that. Because that's the most expensive tool. Whether the patient go for an MRI of a very costly investigation or nothing but history is enough to diagnose, and that all depends upon that. So when a person comes to you with a complaint that I am weak, the first thing to find out is he having weakness. The weakness may not be real. It may be an apparent weakness due to the joint disease, or it may be an overactive antagonistic disease, or maybe if it is a real weakness, how to diagnose a real weakness? Ask for activities or daily living is affected. Suppose Just telling that I am weak does not make this but a weakness. Suppose if the loosening of the chapels, he is unable to get a sitting position. He cannot raise his hand. He cannot comb his hair. He cannot tie his shoelace or button. So that will tell you he's got a real weakness. Once you say he's got a weakness, you know there is a weakness. Next time is human error. So these things all of you know are the features by which you can differentiate human error. But sometimes it's not that very simple in practice. So I'll tell you a story. It's a real story. So a 60-year-old chronic diabetic patient was admitted with his low backache, followed by weakness of both the lower limbs. There was no sensory or bladder complaints. Examination shows that gainers are normal, upper limbs are normal. Lower limb, there was grade 2 power in both lower limbs, both proximal and distal. Reflexes were absent in upper and lower limb. There's no sensory loss except inmate vibration trance and so on. Plantar was new, SLR was negative. So what do you think is the likely diagnosis? So acute presentation, lower limb weakness, reflexia, distal sensory impairment. Naturally, one considers GPS is made. NCV showed evidence of distal, no congestion block, but there is evidence of perineuropathy. CSF was done, we showed elevated protein and also albuminous heterogeneity association. So patient was given a course of IVAG with no improvement. What will you do? On re-examination, there was suspicious sensory level in T7. Then was it possible it could be thoracic myelopathy? See, think back, the patients are diabetic. The reflex loss and CV abnormality could have been due to chronic diabetic state. A compressive myelopathy can produce elevated CSF without any sex, so-called point syndrome. So the patient was ordered MRI, showed a collapse of the decent vertebra with cord compression and biopsy showed plasmacytosis. So sometimes all these features will be difficult. You have to go about with a meticulous exam to differentiate the two. See, element weakness can sometimes mimic UML, for example, as in GPS. Guillain-Barré syndrome can present brisk reflexes and even may not only the acute phase, sometimes persistent brisk reflexes. This is because the axonal variety of GPS, there may not be a reflex loss. Sometimes human weakness can mimic element. Classical example is our spinal shock. This is another problem in patient which I made the mistake in this particular patient. This man got up from bed after an alcoholic bout and noted wrist stop. Examination showed only wrist stop. Weakness was in the following muscles, wrist dorsiflexor. Classically, it was stopped due to radial napron, Saturday and parts. So I put him on cock-up spin and stood out. He did not improve. She was very apprehensive and always asking about is it a stroke and stroke and all. I said no stroke, it will go, it's not like a stroke. But it took an MRI by himself and this is what it showed. He had infarct on the hand knob area of the cortex. So even the apparent element weakness can be due to you. It's called cortical hand syndrome or cortical face syndrome. Now, my point is that how to diagnose in that situation. See, one clue is that always, without much weakness, look for the loss of dexterity of the hand. Ask him to do rapid alternating movements in the hands. And the human lesion more of disability than element. Suppose a grade 4+ power in human lesion will be more disabled than a person with grade 3+ power element lesion. Now, for example, look at this patient's hand. He had normal power, almost normal power of the left hand. He comes with the only problem is that he can put dropping the things on his hand. Power testing was normal. But this is on the left side is affected. The master do this kind of movement with the right hand. See how beautifully he's doing it on the right hand. Now with the affected hand, see, this is how promising it is. So try to do this kind of a rapid movement. You can bring out the human lesion very easily. And we always do what we do in the exam. We ask them to excuse my finger and check the grip strength and say it's normal or human lesion weakness is not there. But in pyramidal lesion, the earliest effect is in the finger abductors or small muscles of the hand and finger extensors. So just by brushing about, by finding that squeezing fingers is normal, it's not correct. Then, how many of you do abdominal reflex? We all do the extensor plan. See, very often the external plan is not helpful. I find that even pyramidal lesion may be sometimes ongoing, sometimes outgoing, a wavering plan. But if you find a symptom of abdominal reflex, it is more important than to make a diagnosis. That give a clue. But hardly we do abdominal reflex. Pronate and all I will skip. Now, so how to diagnose these things? Antigen cell you diagnose when they are the antigen cell for a root and nerve you diagnose depending upon the involvement of the muscles, pattern of involvement. If it fits in with the dermatomal or myotomal pattern, it's a root lesion. If it with the nerve lesion, nerve pattern is a nerve lesion. It's a patchy involvement, neither fitting with the nerve or a root, think of antigen disease. A selective involved muscles, think of a muscle disease or minor lesion. These are all the common things which we teach. And when you get a pure motor affection and wasting, you'd like you to think of antigen. But that does not mean antigens all the time. Some of the nerves are pure motor nerves, for example, deep branches from nerve, posterior nerve, supraspinatus authorizing nerve. A patient coming with small waist muscle wasting or interosseous wasted, arthropoiesis wasted, and confined to the hand, no sensory, you tend to think of more like antigens early development, motor neurosis, but maybe deep branches from nerve. Then for some pitfalls in diagnosing root should be aware. Monoradicular affection, single root affection, always there is more than one muscle affected. No affected muscle is ever totally paralyzed. Somebody is coming to zero power of the muscles, like a full draw, and other muscles are straight. Very unlikely to be a favor. It likely to be concentrated on the pulsar static nerve. Root involvement, single root involvement will not be associated with autonomic disturbances like a sweating loss or loss of air in the distribution. If that is lost, think of nerve. And of course, these things, you know, the distribution of muscle weakness can differentiate. For example, a patient with dorsiflexion plantar flexion weakness is there. In that patient, looking for weakness of the hip abduction can differentiate whether it's an phase from radiculopathy from sciatic. Because hip abductors are not separated by the sciatic nerve or the cord peroneal tibial nerve. That means it has to be in the plexus or the root. In diagnosing peripheral lesion also, certain pitfalls will be aware. In a nerve lesion, all the muscles separated by the particular nerve need not be affected. For example, in early ulnar lesion, the first muscle affected is an adductor of the little finger. The anti-interosseous nerve involvement, the only muscle may be flexor pollicis. The radial nerve palsy, the finger extensor affection is not uniform. It may be maximum in the middle finger and the ring finger. Okay, then another thing is that always beware of symptoms of short duration, however vague they are, because the disease is evolving. So I'll tell you one story. This is a real story which has happened. This is a story of an 18-year-old girl. Before going to the examination, she developed an apparent weakness and came to the doctor. Doctor examined for the thing in common. He thought that this was examined showing it's got a functional weakness. But he didn't even contextual study was also normal. So you get confidence that there's nothing wrong with the girl and can go back. Next day, the weakness something worse and again came back to the doctor. Pre-exam, he did not find any much difference between the previous weakness. So he needed this enthusiasm to make the patient convinced that she's all right. He made him climb down the stairs. She buckled and fell down and injured the knee. Subsequent days, the diagnosis is obvious, but anyone can make diagnosis. That is a case of TBS. So what I'm trying to say is that if the symptoms are short duration, you can't make a diagnosis. Or symptoms are vague before thinking it's a neurotic condition. Give the patient the follow-up. So give some neural vitamins or something as you come after 3 days. So that gives you time for the disease to evolve and make a correct diagnosis. And another problem is still taking this, make sure what the patient needs, just like the vertigo I told. Just this I already told, weakness does not mean real weakness. Then coming to the stiffness. Is it the stiffness, as you already get stiffness, you think, oh, they get pyramidal spasticity. But the stiffness also can occur due to postural dysfunction. They complain of tight feeling of the limb. The clue to differentiate is that if you show a sensory loss or a postural dysfunction, the tight feeling will be present all the time, whether the patient is walking about or standing on the limb. But This difference due to pyramidal lesion occur only when the patient is walking or lying down. It may not be there. So simply asking at what time it occurs, then you can differentiate it. Many times we find examination that say muscle in a pain, in a person with pain is difficult. For example, cardiac exam, periarthritis of the shoulder. There's got a periarthritis, you have an apparent being of the deltoid. So in that case, what you do is that you passively move the limb to the maximum tolerable elevated position and break the muscle. That asymmetric testing can make the examination become easy, or is the one you do to differentiate or find out weakness if there is associated joint problem. Then we hardly, another thing which we found that we examine the patient weakness in the bedside. But what is the normal power? See, the problem with MRC grading is that the power of the patient is compared with your power. But the patient's lower limb is so strong that it is way above your power of the upper limb. So how can I break a person with grade 4 power of a lower limb? So the lower limb is concerned, muscles are so powerful that minor weakness will not be detectable unless you put the muscle in the most discouraged position. So always make the patient to stand on heel, stand on toes, ask him to get him in a sitting position or stand on one leg to find out the weakness of the muscle. Unless you do that, you examine only at the bedside, you are likely to miss lower limb weakness. I think we'll skip these things. And just lastly, the muscle weakness. See, many times we can't do individual muscle testing. See, we don't have much time to do all those things. Certain 2-3 tidbits which you can do is that the common condition is the carpal tunnel syndrome. When you look at the abductor polys previously, you can also easily break it. We are not sure whether it is weak or not. And upon this also, the one simple test is what is called nail sign. This is the normal, the patient has to oppose the thumb and the little finger. This is what normally one does too. Look at the right hand. It cannot oppose it. The thumb goes to the side of the little finger. We find that thing that his opponent is weak, that is like said to me early carpal tunnel muscle is weak. This is the advanced machine or advanced phase. The patient cannot oppose at all, goes to the side. It's called a nail sign. Then another thing is the bottle sign. I think we can skip. You ask the patient to hold a bottle like this. If there's a gap between the bottle and the hole, that also tells you like the weakness of the abductor polys reveals in carpal tunnel syndrome. In median nerve palsy, the gross examination finger may be normal, but the only muscle or main muscle effect may be the index finger. So look, ask the patient grip like that. You find the finger in the index finger standing out. You find that that's assessed to be median nerve palsy. This other patient, he comes to complain that he cannot tie his door. That's only a complaint. Cross examination is normal, power is normal, everything was normal. But when I asked to do the thing like that, see, the only thing is thumb is not flexing. All of the muscles are flexing. He's got a pointing thumb side. What he had was anti-intuition nerve palsy. So these things can happen. So similarly, O test for the percentage of the deep anti-intuition nerve, where there's a weakness of the pressure polys, longest and the percentage of profundus, common sense 0. And in ulnar nerve, the first muscle affected or earliest muscle affected is the fourth palmar intuition. So the little finger will be jutting out like that. The complaint will be that whenever he puts the hand into the pocket, the little finger will jut out or it will not enter into the pocket. That's a sign of early sign of ulnar nerve bottom side. So at the last part, I think I would, can it take 10 more minutes? Am I audible to you?
Yeah, Atreya.
Sure, sir.
Just 10 minutes more?
Yes, sir.
Okay. Yeah. The other problem is the paresthesia. This is the real tough problem for anyone. The most difficult part of neurology examination is sensory system examination, whether it's the paresthesia or the pain. Because the symptoms are subjective, we have to believe what the patient says. So if a young patient comes, female, especially female, comes to you with a complaint of paresthesia or a small area of the trunk, with no other findings, we are unsure as to whether it's a part of the multitude of many other somatic complaints. Whatever he has, she said yes. Pain there, pain here, paresthesia there, here.
like aching pain of various parts of the body, or a demyelinating plaque setting in the posterior column. How can you say C-Water may have a multi-order complaints? And even the term numbness itself is problematic. People may use this term not only for paresthesia, but also for many complaints as well. For example, even stiffness and weakness also they use a numbness. So the first step is to find out what the patient really means. And the problem in sensory complaint is that you should remember the old dictum that sensory symptoms precede the sensory signs, and motor signs precede the motor symptoms. That means if a patient complains of weakness, on examination there is no weakness, you are sure that there is no weakness. It is speaking, unless it's an episodic weakness that may see. On the other hand, if patient complains of paresthesia, you find no sensory loss. You cannot say his complaint is not getting it. You must have seen patients having stroke who complains heaviness on one part of the body, one half of the body, the paresthesia. But exam sensory system, everything is normal. So whenever patient complains of sensory loss, they ask about objective evidence of any sensory dysfunction, like for example, imbalance while walking at night, loosening of the chapels with his knowledge, dropping of the things from his hand, etc. To complicate matters, there are non-neurological causes of paresthesia, like hypocalcemia, hypomagnesemia, hypoventilation syndrome, panic attack, fibromyalgia. They're all complaint of and drug side effect of drugs like Diamox, Dr.M.A.Andrews, etc. Now, how to approach paresthesia? If someone comes to you with a complaint of paresthesia in a limb, it says only one thing, that the lesion is the sensory system and most likely involving the pain-to fibers. The lesion can be anywhere in the sensory part. Where is the site of affection depends upon the distributed sensory system. One can generally say that if the nerve lesion is a distribution of that of the nerve, root means sensory loss occurs in the dermatomal pattern, intermental lesion in the halfway for jacket-like distribution, tract lesion, pain paresthesia in the whole limb on one side of the body. It may be distal symmetrical. Now, I think I'll skip this thing. Now, certain pitfalls should be aware. In a peripheral nerve lesion, the sensory loss may not involve the entire sensory distribution. It may be confined to the small area. For example, carpal syndrome, the patient may complain of paresthesia only in the middle finger. In ulnar nerve may be confined to the little finger, and the radial nerve, the web space. The web space also, the sensory distribution can vary widely among different patients. It may be confined here or maybe as complete as this particular hand. And pain and paresthesia may radiate beyond the territorial supply. For example, carpal syndrome, paresthesia may spread beyond the rest. Ulnar nerve paresthesia may occur in the middle. But if you have sensory loss, will be confined to the distributed nerve. Then the root lesion, the severe sensory loss is seldom seen in the right due to considerable overlap in the dermatome separated nerve roots. Therefore, absence of sensory loss does not exclude the possibility of a lesion affecting a single root. Again, it may be confined to a small portion as you already know about it. The 6 radicular for the sensory loss may be only in the thumb. C7 may be in the index finger or the middle finger. C8 may be confined only to the little finger, L5 or the late, etc. Then, see, another thing is that progressive lesions of the spinal cord, compressive spinal cord, say the high cervical region. The paresthesia may be much lower in the lower ear, maybe the distal part. As the compression progresses in the cord, the paresthesia gradually ascends up. So if you maybe initially paresthesia may be here, then becomes here, then goes up to the mid-thoracic level, then in the end only comes to the level of actual lesion. So if you happen to see the patient, the initial phase, you may erroneously diagnose in neuropathy because sensory loss is confined in the distal part. So what are the points in that case how to differentiate? In peripheral neuropathy, there is a graded sensory loss in the distal part. The sensory level for touch and pain are exactly the same level in peripheral neuropathy, unlike in a cord lesion, where the different sensations are affecting different times, and the levels are different for the pain as well as for the touch or posterior. In peripheral neuropathy, by the time the sensory loss extends beyond the knee, upper limb should be invariably affected. And the sensory loss in the trunk starts in the midline anteriorly in peripheral neuropathy. A circumferential neuropathy suggests a spinal cord lesion. And another two we want to stress, the sensory loss in high cervical compression may mimic a radicular pattern. This again, these sensory loss may be initially confined only to the little finger bilaterally or unilaterally and spreads up like that. Somebody comes to you with paresthesia of both hands in the middle part. You may tend to diagnose bilateral palsy, but always keep the possibility of high cervical cord compression. That will be the beginning of that cervical myopathy. And cervical myopathy can present what called clumsy hand syndrome, or the impairment of the posterior column sensors alone may be affected before the weaknesses occur. This again I think skip. Then I will finish my talk by telling that all peripheral neuropathies need not produce low and sensory loss like ganglion neuronopathies, which may not be confined to the distal part, may start proximally, it may be patchy in moment. And when you suspect sensory functional sensory loss, it did not correspond to the organic distribution and the suggestion. It split the midline, circumferential sensory loss around the body and extremity, like a time up to that one particular level. Think of function. And this is one bedside test. You put the tuning fork on one side of the frontal bone. Even if the one side is affected, the patient feel the vibration on the other side because it is transmitted to the other part of the bone. Similarly, the sternum, the patient on one, you may be saying that it may be felt on one half of the frontal bone, not other part, means it's unlikely to be a functional, unlikely to be a functional sensory loss. I think I literally exceed my time. I'm extremely sorry that I have to go into it and because of problem with the connection. So I thank you all. Thank you once again for your patience.
Thank you, Madhu sir, for the excellent review of most of the parts of neurology. I think there will be a lot of questions, and due to lack of time, I think we can have the discussion at the end of the session during the question answer session if sir is there.
Okay, I'll be here. I'll be here. No problem.
Okay, so we can have the questions at the end of the session during the
sure.
Okay. Over to the organizers for the general body.
Thank you. Please disable the screen, sir. Okay. Now we will start the general body meeting. Pavan, are you there?
Yes.
Okay.
Start here.
Okay, start here. Okay. The meeting is called to order. Silent prayer. Okay, thank you. Flag salutation by Secretary Dr. Pavan.
Flag salutation. We, the members of Indian Medical Association, stand before you to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, Jai IMA.
Jai Hind, Jai Hind. Thank you. Now, a very good evening and a happy new year 2020-21. I welcome you all the delegates to the respected State Joint Secretary Dr. Jain Chimman, Thrissur Branch Secretary Dr. Pavan Madhusudanan, the faculties of today's CME, Dr. Professor Mohan Madhusudanan sir, Professor Dr. M.A.Andrews, Principal Government Medical College Thrissur, Dr. Ramkumar Menon, Managing Director, Atreya Speciality Hospital Thrissur, Dr. V.T. Haridas, Neurologist, Atreya Hospital, Headache Clinic, Dr. Rani Menon's Eye Hospital, and Dr. Arun Kumar, ENT surgeon, and the senior leaders of IMA Kerala State Branch, Dr. Srivilasan, Dr. Devdas sir, and Dr. Salman Kushan, and our treasurer, Dr. Joseph George, and all the colleagues of our branch. I welcome you all to this general body meeting and the CME for the first general body meeting of the year 2020-21, and also the first CME which is already started an hour and a half back. Today many of our colleges had the first shot of Covishield, and as far as I know without any AEFI. Hope by the end of this month all our frontline warriors will be receiving the vaccination without any untoward effects. We are planning 6 CMEs on post-COVID complications and events, starting the first one on next Saturday, 23rd January, on Zoom online platform with a Dr. Nisha Nijil Harun, an endocrinologist and diabetologist from Toronto, Canada, who will talk on long COVID and diabetes. That will be the first one. Next one will be during the next month. Our cultural wing will be celebrating New Year's Eve on 26th of this month with a variety of cultural extravaganza. Also, we will be observing the start of the Anti-Leprosy Day on 30th of this month in association with the Dermatology Club with a CME. I request all to note these dates and participate and make it a success. Also planning some activity on the Republic Day which will be announced later. I also compliments and express to Dr. Ramkumar Menon, Managing Director, Atreya Speciality Hospital, Thrissur, for today's scientific session. And I am not wasting not much time. Now I invite Dr. Jain Chimman, State Joint Secretary, for his address. Over to you, Dr. Jain.
Thank you, Joy, sir. Thank you. And definitely, IMA Thrissur has been doing a tremendous job. And this year also, we have started off in earnest with a very relevant topic. And the sessions that was already over was very interesting and very practical. I'm sure all those who had attended definitely would have gained much by the presentations by a very renowned neurologist, Madhusudanan sir. So, and we have got another session that is going to come up, and that is headache. And we have got an expert panel to discuss on headache. So the start of this year has been excellent by a very relevant topic and a very relevant team of doctors that is going to present to us. So congratulations once again, Dr. Joy and Dr. Pawan, for coming out with such interesting and program for our members. And today is a very important day, as President said, because as health workers, we are in the forefront of, we have been in the forefront of fighting COVID-19 the last year. And now the much awaited vaccine has arrived, and many of us, our state secretary has also been lucky enough to receive the first dose today. And many of our senior leaders have received their first dose, and many of our colleagues have been selected at random, and definitely they have received their first dose, and nobody has had any problem. And IMA is definitely has partnered with the central government and state government, and so we should be in the forefront. We should be there to propagate the efficacies of the vaccine. So wishing a very bright new year today, since it's a very auspicious beginning, because we have started off with the vaccination, much awaited COVID vaccination. So thank you, and wishing all the best for today, for this year, and happy new year to all colleagues and senior leaders. Thank you. Thank you. Thank JIMA.
Thank you, Dr. Jain Chivan. Actually, today's program is meticulously planned by our Vice President, Dr. Santosh Babu, and Atreya MD, Dr. Ramkumar Menon. A very big thank you to them. Now I invite Dr. Pawan Madhusudanan, our secretary, for the minutes and the activity report. Over to you, Dr. Pawan.
Hope the slides are visible.
Yeah, visible.
So I'll just go through the activity report of the previous month. So this is the general body which we conducted last month on December 19th, which was organized by the Aster Medcity. It was conducted on 19th of December, Saturday, 7:30 p.m., presided by Dr. Joy Manjila, and State Joint Secretary Dr. Jane Chimman. He addressed the gathering and updated on the progress of the protest against the CCIM amendment. Minutes and activity report were presented by the secretary, and it was passed in the general body. Sign week session was organized by Aster Medcity. Dr. Krishna Kumar, senior consultant in vascular and reconstructive surgery, he took a session on plastic surgery overview, and it was followed by discussion. Then we had an update on the COVID-19 vaccine, IMA Thrissur, along with the ISA Thrissur City branch. It was conducted on 21st of December, Monday. Dr. Nitin Shah, pediatric hemato-oncologist, who is the author of several textbooks, including the IAP textbook on vaccine. He updated on the COVID-19 vaccine and elaborated on the different types, its safety, and all other aspects of the vaccine. And we had Dr. Binu Arikel, who is the additional professor of community medicine from GMC Thrissur, who moderated the session. Then this is the picture of the Christmas celebration conducted by IMA Thrissur along with ISA Thrissur at Dr. Vimy Memorial Cerebral Palsy Center. Dr. Joy, President of IMA Thrissur, and Dr. J.S. Nivin, President of ISA Thrissur City Branch, and Dr. Arun, Secretary of ISA, addressed the gathering, and the Christmas kits were distributed to the parents. This is Dr. Abhaya, who took a session, awareness session on palliative care on 23rd of December. She's the district palliative medical officer and convener of the women's wing of IMA Thrissur, and there were almost 75 participants for the event. It was conducted along with the NSS unit of Mother Arts and Science College. Then this is a picture of the wildlife photography exhibition, which was conducted by Dr. Lindo John and Dr. Krishna Kumar of Amala Medical College, which was supported by IMA Thrissur. A lot of IMA Thrissur members visited the gallery. The gallery was at Lalithagala Academy Hall from December 23rd to 30th of December. Then we had the IMA celebration, IMA Blood Bank Christmas celebration, which was on 23rd of December, attended by Dr. Joy Manjila, Director of Blood Bank Dr. V. Govindagutti, and the past Director Dr. C.N. Parameswaran, and Medical Officer Dr. Balagopal. Then we had another program, as you all know, the ongoing Zumba sessions. It was conducted as a part of the Christmas celebration. It was named Merry Fitness, done on 27th of December. And Dr. Jane Chimman inaugurated the program, and the meeting was presented by Dr. Joy Manjila. Dr. V.C. Manoj, who is the president of NNF Kerala and chairman of the Doctors Fitness Club of IMA, he addressed the participants. And there was a Christmas special Zumba session led by Dr. Manoj and Mrs. Pooja Manoj. These are the pictures. Then IMA celebrated the New Year with the IAP Thrissur and NNF Thrissur, which was an online program. Dr. Reddy Chandakumar, president of IAP, Dr. Jane Chimman, joint secretary of IMA, Dr. Gopi Kumar, the president secretary of IMA Kerala, they all participated. Dr. Gopi Kumar inaugurated the session. Dr. Joy Manjila presided the meeting, and Dr. V.C. Manoj is the president of NNF and chairman of IMA Fitness Club, addressed the gathering, followed by a New Year Zumba workout. Then we had the IMA Thrissur IMA calendar for the year 2021. It was released on January 1st, 2021 by Dr. P. Gopi Kumar. That was also during the New Year Zumba fitness workout program on January 1st. The calendar was edited and composed by Dr. Arun Krishna. Then IMA Thrissur participated in the COVID vaccine district task force meeting, which was organized at General Hospital Thrissur on 8th of January. The meeting was presided by the new mayor of Thrissur, Mr. M.K. Varghese, and Dr. Sridevi, Superintendent of General Hospital, Thrissur, Dr. Santosh, the WHO consultant for North Kerala, and Dr. Unnikrishnan, RCH officer, they all participated. And also the representatives from other social organizations got involved in the meeting. Then this is the IMA Thrissur Executive Committee meeting and New Year celebration at Hotel Elite on 9th of January, Saturday. So we had the invited guests from doctors from Apollo Adlex Hospital, Karagutti, and the secretary presented the minutes of the previous executive and was passed in the meeting. And New Year celebration was by by cake cutting by Dr. V. Govindagutti, the past president of IMA Kerala, who is also our member, senior member, and sub-faculty members. They presented the programs for the upcoming month, and Dr. Arun Krishna presented the glimpses of IMA Thrissur with a short video for the previous year. Dr. Nivin projected the IMA Thrissur calendar for the year 2021, which is a tribute to the COVID-19 warriors with a PowerPoint presentation. And this is the meeting which was organized by the district administration for the COVID vaccination program. The meeting was chaired by the district collector, Sri Shanavas IAS, and the meeting was attended by DMO, RCH officer, and other government agencies. Government and private medical colleges also participated, and the meeting emphasized on the meticulous program management and effective management of AEFI, any adverse effects following immunization during the vaccination session, and also decided to spread a very positive message regarding the vaccination to the public. This is the picture of the online New Year celebration, which was organized by the WDW on last Sunday, 10th of January. Dr. Shobana Mohandas, who is the chairperson of WDW, welcomed the gathering. Dr. Joy Manjila presided, and we had Dr. Kavita Ravi, the chairperson of IMA WDW, Kerala State. She was the chief guest and inaugurated the event. Dr. Jain Chimman also addressed the gathering and was followed by games and quiz competitions for the kids and family, and was organized by Dr. Abhaya and Dr. Anila Matthew. This was the district AEFI committee meeting for the COVID vaccination. It was held yesterday, January 15th evening, and representatives from the DMO, medical colleges, and WHO consultant also participated, discussed regarding the effective management of AEFI during the COVID vaccination. And these are the pictures of the vaccine launch, which was today morning. IMA Thrissur also participated. These are the few pictures, and lot of doctors, including the members of our IMA, they also got vaccinated today from General Hospital as well as from the other private hospitals in the Thrissur. They were called to the General Hospital, and they all cooperated in the vaccine session today. IMA blood bank activity for December, we had 992 units collected at the blood bank. So this is a short description of the activities for the previous month. Over to President.
Thank you, Dr. Pawan, for the lucid presentation of our IMA activities. Now, as we are running out of time, I hope we can close the general body meeting. Any comments, from the participants? Pavana, don't close the activity, share screen. If there are nobody wants to say anything, then we will move on to the vote of thanks session. I invite Dr. Pawan for the vote of thanks of the general body. Over to you, Pawan.
Yes, thank you. So I am officially thanking the participants for the general body, and we'll be continuing with the CME. So I request everyone to stay on. So let me take this opportunity to thank our president, Dr. Joy Manjila, who is leading the IMA Thrissur. Thank you, Dr. Jain Chimman, the state joint secretary, for attending today's function and today's general body and addressing the gathering. And a special thanks to Atreya Hospital for helping us organizing today's meeting. And it was the initiative was taken by Dr. Santosh Babu, who is our senior vice president of IMA THRISSUR. Let me thank Professor Madhusudanan sir for that excellent talk. I think we had a lot of audience today, especially to listen to your talk. Thank you so much, sir. Thank you for your excellent session. And I request you to come back to IMA THRISSUR again for further academic sessions. Thank you very much, sir. Let me extend my thanks to Atreya Hospital MD Dr. Ramkumar Menon, sir. Thank you for helping us organizing today's meeting, today's general body. Once we start the physical meeting, probably we can conduct one more physical general body with the help of Atreya Hospital. And I wish all success to your new venture, to your new neurology clinic and headache clinic at Atreya. Extending thanks to our today's faculty, also to the chairperson of today's session, Professor M.A.Andrews, sir. Thank you very much. He is our member. He is a regular attendee and academic person who associates with IMA THRISSUR always. Thank you very much. Extending thanks to Dr. V.T. Haridas, Dr. Arun Kumar, and also we have today we have Dr. Rani Menon, and they will be joining us with further CME sessions. I thank everyone for joining us today, and we'll continue with the CME session. Thank you. Thank you, everyone.
Thank you, Dr. Pawan. Now we'll move on to the next scientific session for and the meeting, general body meeting is closed, and for the session 2. Over to you, Dr. M. Andrews, for the further proceedings.
Next is headache. Headache many times is a headache for doctors. Even though only 3 to 6% of patients attending a general OP is having a secondary headache or a headache due to underlying pathology, many times it is a major problem for us and also for the patients. To discuss this, we have got Dr. V.T. Haridas. He also doesn't need an introduction. He is an active member of THRISSUR IMA, and he is a alumnus of THRISSUR Medical College, and he had been trained by Madhu sir also. So over to Dr. Hari for the discussion.
Thank you, Dr. Andrews. Am I audible? Shall I start sharing my screen?
Audible.
Dr. Haridas, sound is not there, audio is not there.
Is it? Okay. Is it for everyone?
Yeah, we can hear, we can see.
Yes, audible.
No, you are free.
I'll do one thing, sir. I'll just.
Better, Dr. Hari, you present it rather than the video.
Yeah, that's what I'm going to do, sir. Just get it. Just hold on. Are the slides visible? Am I audible? Hello?
You are audible. Audible.
Shall I start?
Okay.
So we human beings come in different styles and with different smiles, and headaches are also like that. They come in different forms. And headache is a very common problem. If you've got a head, you are destined to have a headache. That's why the LLC used to say, the problem is it results from wide variety of illnesses. And some of them have grave underlying pathologies. Some of them will be very simple. And headaches are encountered by specialists in almost all specialties. We have an international headache society. They have classified headache into mainly 3 parts. Part one is the primary headache, where headache is the main problem, and there are no other underlying structural disease. Part 2 is the secondary headache disorders, where there are underlying structural disease which produce a headache. And the third part is the painful cranial neuropathies or other facial pains. Primary headaches is very common. The common types are migraine, type headache, and trigeminal autonomic cephalalgias and other primary headache disorders. Migraine is a very common topic during discussions, and post-lockdown, we had a lot of webinars, and most of them were about migraines. And I assure you that I'm not going to talk on migraine this evening. And the part 2 is the secondary headaches, which is mainly due to an underlying structural disease. It can be a trauma, or maybe vascular disease like a stroke, or it can be due to substance abuse, or caffeine withdrawal can produce a secondary headache. It may be due to infection of the meninges or the brain, and disorders of homeostasis, or a headache due to other ENT and ophthalmologic causes like sinusitis or glaucoma, or a headache due to a psychiatric disorder. And the third part is a painful cranial neuropathy. The best example is our trigeminal neuralgia. Now, to make a diagnosis of migraine or tension headache or cluster headache is a literally simple job. If you have studied up to final MBBS, you know how to diagnose a migraine. Like when a young lady comes with a unilateral throbbing headache with a phonophobia and photophobia and vomiting, episodic in nature, we can actually make a diagnosis of migraine very easy. Similarly, with the tension type headache, depending upon the distribution, or if the patient comes with a headache, which is mainly around the eyes and has got other associated autonomic symptoms, you can make the diagnosis of cluster headache. But the problem is to differentiate this migraine and other primary headaches from the secondary headaches. That's a real challenge. And that's what we have to do in a busy OPD. To help that, we have got some beautiful mnemonics like this one, SNOOPs, SNOOPPP. For example, if the patient comes with systemic symptoms like fever, chills, never diagnose a primary headache. They can have underlying serious disease like metastasis or infection. If the patient has got neurological symptoms or deficits like a weakness and a headache, think about stroke and mass lesions or encephalitis. If the patient is elderly, say more than 50 years, and he has got his headache for the first time after the age of 50, think of other things like temporal arteritis or glaucoma. Then the onset of a very severe headache, which peaks within 1 minute, that's called a thunderclap headache. This is always a ominous headache, and I'll be discussing it later. This is usually due to a secondary disease like a bleed or a subsequent hemorrhage. If the patient has got a papilledema, you know that it's due to a raised intracranial pressure, so never diagnose a primary headache with a papilledema. Then positional headache, especially orthostatic headache. Patient gets up and feels a severe headache. That means there is something grossly abnormal and it is not a primary headache. Similarly, headache precipitated by a Valsalva maneuver, or if the patient has got a long-standing headache and over that he has got a new onset of different type of headache, or there is a progressive worsening of his headache suddenly for the last few weeks, always think about a secondary cause like a tumor evolving there. Now, these are all typical headaches. Now, there is a lot of headaches which are very rare. They come with different presentations, and they are the atypical headaches, and they are the real challenges for a physician. These atypical presentations may be atypical triggers or atypical sites or atypical accompaniments. And these atypical headaches may produce severe headache to the treating doctor. Because it's very difficult to make a correct diagnosis in a very busy clinic. So there is a high chance of an underlying serious pathology. And because of this, many of them are misdiagnosed or mistreated. So atypical headaches are the real headache for the physician. In the next few minutes, I'll be touching upon some uncommon or atypical headaches, why a doctor, irrespective of his branch of medicine, should know about them. And my aim is to make you aware of some uncommon headaches and also to make you know that all that aches are not migraine. So there are so many other headaches beyond migraine and tension headache which we should be aware of. I told you about the atypical triggers. All of us cough, but some of the persons develop severe headache following a bout of cough. And this is called a cough headache. This is the example of a bank officer with a headache. He's 38 years old. He cleaned his garage and he developed a dry cough and was refusing to go. His physician gave him cetirizine and cough syrup. The cough reduced in severity, but he started getting headaches after every bout of cough. It was mainly on the occipital and temporal region, lasting for about 2 to 3 minutes. So this is a primary cough headache and is usually seen in males above the age of 40. It lasts from 1 second to 30 minutes, and usually they respond very well to beta blockers or indomethacin. Primary cough headache is a benign thing, but there is a catch. 30 to 40% of cough headaches are secondary due to a serious underlying disease. So whenever a patient comes with a cough headache, never make the diagnosis of a primary cough headache. There will be a serious underlying disease. And what are these serious underlying disease which produces a cough headache? One is our hearing malformation, Arnold's hearing malformation, then posterior fossa lesions, and other lesions like other brain tumors. As you know, in Arnold's hearing malformation, there is a herniation of the cerebellar tonsil to the foramen magnum. So as a result, there is an overcrowding of the foramen magnum, and this will result in the obstruction of the CSF flow. Look at this MRI. There is a descent of cerebral tonsil by about 11 millimeters to the foramen magnum. And this is a CSF flow study. You can see that there's a nice flow of the CSF along the anterior border of the brainstem. But in the posterior part, you cannot see any significant flow. Nice flow over here, but no significant flow here. So this is because of the obstruction of the CSF. What's the treatment? What we do, or what the neurosurgeons do, is they do a posterior fossa craniectomy. They remove a part of the brain, remove a part of the cranium, and if needed, sometimes the C1 to C3 arches as well, so that there is no overcrowding of the foramen magnum. So any patient coming with cough headache, always rule out an Arnold's hearing malformation or a brainstem lesion. Now, lockdown effect, all of us have got more time to exercise, and many of us have started taking up exercise in a big way, going to cycling, putting up a gym at home. So this is a special type of headache which is called the primary exercise-induced headache. This is precipitated by strenuous exercise, and most of them doesn't have any underlying pathology. And it can occur immediately after exercise, can last from few minutes to up to 48 hours. And they also respond well to indomethacin and propranolol. But then I'm telling you about another type of exertional headache. This one is that of a male. He was 44 years old. He always complained of exertional headaches and associated with the mild chest discomfort whenever he did something like a brisk walking or playing table tennis. So a heavy exertion bringing out headache as well as chest discomfort. So that's a catch. He was a non-smoker, but he had history of dyslipidemia and a family history of diabetes. When we examined him, his neurological system and cardiological examinations were normal. His brain MRI and MRI were done to rule out an underlying serious brain disease, was again negative. His resting ECG was normal. There was no features of CAD. But since he complained of exertional chest pain, he underwent a TMT, and that TMT, treadmill test, turned out to be positive. And subsequently underwent a coronary angiogram, which showed a total occlusion in the proximal left anterior descending. And this LAD was successfully treated with a single drug-eluting stent. You can see the angiogram, no flow in the left anterior descending, and this is after putting the stent. Subsequently, the patient was discharged with dual antiplatelets. And in the 3 months follow-up, he didn't have any headache. We repeated a stress test. There was no chest pain, no ECG changes, and no headache. Because during the first TMT, when he did the exercise, he had STT changes along with headache. But this time, no headache, no ECG changes. So the stent was working wonderfully. So this is what we call a cardiac cephalalgia. Many times we think about headache as a neurologist problem, but cardiac disease also can produce headache. So we diagnose cardiac cephalalgia based on the presence of severe headaches, which is worsened by physical exercise or stress, relieved with rest or nitrate administration. And the mechanism is said to be a referred pain. As you know, embryologically, the heart develops from the cervical segments. So the pain from the heart may be referred to posterior part of the neck as well as the occiput. There are theories other than that, like venous stagnation is also there, but we are still not sure about the exact mechanism of cardiac cephalalgia. This is another referral from the gynecology department. This is a 30-year-old lady undergoing treatment for polycystic ovarian disease. She was obese. She had a BMI of 35.25, which is morbid obesity. She was referred for headache of 2 months duration. There was a diffuse, non-throbbing headache. And the most interesting thing was it was associated with transient visual obscurations. That is, whenever she turned the neck suddenly or whenever she bent down and straightened quickly, she used to have an obscuration of her vision. And 2 days prior to the consultation, she developed diplopia, and that was the reason why the gynecologist asked the patient to meet the neurologist. And on examination, she was found to have a left lateral ictus palsy. And this was her fundus picture showing bilateral papillary edema. So an obese lady coming with a headache, with the transient visual obscurations and features of raised ICT. We did an MRI. There was no space occupying lesion, but look at this ventricle. It's very slit-like ventricle, as if it has been narrowed down to a very small, narrow slit. And her optic nerve head was looking very prominent because of papillary edema, and the optic nerve was tortuous, and she also had an empty cellular syndrome. So this classical clinical finding and radiological features suggest something called as a benign intracranial hypertension. Previously, we used to call it BIH or benign intracranial hypertension or pseudotumor cerebri, but the current term is idiopathic intracranial hypertension. And usually they develop a visual impairment. They can have an enlargement of the blind spot as well as a reduction in the visual field and constriction of the peripheral visual fields. And usually the etiology is obesity or hormonal changes or hormonal pills, including OCP or vitamins of A, especially in young children. And we usually start treatment with the Diamox and serial lumbar puncture and weight reduction. If the patient does not respond to conservative measures, to save the sight, we may have to go for a CSF shunt or optic nerve fenestration. So the most dreaded complication is a papillary edema leading on to an optic atrophy and blindness. And that's why we no longer call this a benign intracranial hypertension, because it can produce significant visual loss if left untreated. In my patient, the patient had a high CSF pressure of 32 centimeter. She underwent the serial lumbar punctures and CSF drainage. She was started on Diamox, which will reduce the CSF pressure. That's acetazolamide. And she's being followed up with visual field assessment, and her visual field has improved. So we are not considering a CSF shunt in this patient. Now, another important point you have to remember that other disease also can mimic so-called idiopathic intracranial hypertension, and that is a chronic cerebral venous thrombosis. You can see that in this patient, the transverse sinus as well as the sigmoid sinus is not seen. This is thrombosed, and you can see a nice thrombus sitting here in the sinus. So these patients also present with the classical features. They have headache, they have visual obscurations, they have papillary edema. And many of them will be on some drugs like OCPs or drugs which produces procaryonic state. So whenever a patient comes with a so-called idiopathic intracranial hypertension, before labeling it as idiopathic, we have to get an MRI and MR venogram to make sure that this is not a cerebral venous thrombosis. So from the high pressure, we'll go to the low pressure. This is a story of a 32-year-old medical representative, and I'm sure at least 30% of you sitting there in the crowd would have seen him. I will not tell his name. He's in the Lupin lab. So this fellow has a 4-year-old son, very mischievous fellow. They were playing, and he was lying down, and the son jumped and sat on his back while he was lying prone. He felt a severe neck pain and the shoulder pain. The initial 2 days, he had restricted neck movements, and his occipital and neck pain persisted, in fact worsened. But there was no upper limb radiation. He went to an orthopedic surgeon. He did an MRI of the neck, and there was a mild C5-6 intervertebral disc prolapse. So a diagnosis of intervertebral disc prolapse was made. He was put on traction and analgesics. He was somewhat better. But on becoming ambulant, neck and occipital pain recurred, and there was no vomiting. So he has got a severe neck and occipital pain. Now, a few points in the history would have given us the clue in the initial first day itself. And that's why Dr. Madhusudanan sir said that everything is in history. For a neurologist, the most important weapon is his tongue and his analytical brain, and everything is in history. Sherlock Holmes said, data, data, data. I cannot make bricks without clay. So for building up a diagnostic possibility, you need data. And for that, you need a patient history taking. So this patient's history, he has a height was the neck and the occipital region. The type was an aching type. And this is the most important thing. It increased on standing and relieved within few minutes of lying down. So this was something like an orthostatic headache. Headache coming when standing up and relieved by rest. So diagnosis, this is due to intracranial hypotension. There is a reduction in the CSF pressure. So due to the CSF leak, the CSF pressure lowers. As you know, one of the function of the CSF is to give a buoyancy to the brain inside the skull. Our brain weighs about 1.4 kilogram, but because of the CSF, its effective weight comes down to 0.18. It is just like a ball floating in water. So once the CSF pressure goes down, CSF pressure lowers, this buoyancy is lost. And in fact, there is a significant traction on the meninges due to the weight of the brain. And probably this is the reason for the headache. So the headache worsens on standing up and relieves on lying down. You can see this is a normal MRI, and this is an MRI with the person with spontaneous intracranial hypotension. You can see this is a tent. There is a concavity of the tent. The CSF spaces has increased. The distance between the corpus callosum and the brainstem also has come down. So there are a lot of signs like empty cellular syndrome. All these are seen in spontaneous intracranial hypotension. So this is a low pressure headache, also called SIH. And if the low pressure headache is severe, they can develop a bilateral subdural hematoma, as in this patient. So whenever a patient comes with orthostatic headache and bilateral subdural hematoma, always think about spontaneous intracranial hypotension. And there's an MRI showing a CSF leak here. So there is a dural or meningeal tear and the CSF is leaking from here. So what is the treatment? If it's a very small tear, many of them respond spontaneously to rest and hydration. But if they are not responding to rest and hydration, the next step is an autologous blood patch. It's very simple. Take patient's own blood, and inject it in that space. So the blood goes and seals the particular defect. And in up to 60 or 70% of the patients, this is very useful. Sometimes we have to repeat once again. If the dural tear is very large, this will not respond to blood patch, and sometimes they may have to undergo a dural repair. So this is a spontaneous intracranial hypotension resulting from a dural tear and low CSF pressure. Another interesting patient from the psychiatry ward. She was admitted for psychogenic unresponsiveness, and her history was very dramatic. At 8 o'clock, her husband left for work in the bus. And about half an hour later, she receives a phone call saying that the bus capsized into a canal and there are a few casualties. So she was really upset. She reacted violently, became hysterical, thumped her chest, cried aloud. She did almost everything that is shown by a heroine in the serial. But 3 to 4 minutes later, she shouted, "And the thala potti pona, my head is bursting." She vomited. She became unresponsive. And a few minutes later, husband has escaped unhurt. He returned home and found that his wife is unresponsive, and he took the wife to the casualty. So a young lady coming with a loss of consciousness, hearing a bad news, my CMO was smart enough to make a diagnosis of hysterical conversion reaction. Pinprick, no response. Spirit of ammonia, no response. The blood sugar was normal, BP was maybe 140, 100, pupils were normal. But that was the most important sign, that was a neck stiffness. And see the CT scan, it shows a massive subarachnoid bleed. So acute severe headache, always rule out an intracranial pathology. And this is a classical case of an acute severe headache or a thunderclap headache. So the most important point that I want you to carry home from this particular 20-minute talk is this thunderclap headache. What do you mean by thunderclap headache? According to the definition, thunderclap headache is an explosive, abrupt onset headache that reaches peak intensity within 1 minute from the onset. For example, take the case of migraine. After the onset, it usually peaks and reaches a peak after 30 minutes or 1 hour. But thunderclap headache, it's very sudden onset and reaches the peak within 1 minute from the onset. This TCH or thunderclap headache may be a presenting feature of many underlying ominous diseases. So thunderclap headache, always think about a bad disease. What are these bad or ominous diseases? One is subarachnoid hemorrhage. Unruptured intracranial aneurysms also can present like that. Arterial dissection, cerebral venous thrombosis, pituitary apoplexy, as you've seen in a gravid patient in the 3rd trimester. Sometimes they develop pituitary apoplexy, acute hypertensive crisis. And another interesting one is reversible cerebral vasoconstriction syndrome. Sometimes a colloid cyst, cerebral fluid hypotension, all this can produce a thunderclap headache. So when you are coming across a patient with a sudden onset of acute severe headache, taking within 1 minute, do not jump into conclusion. And this is a case history of a romantic night spoiled by thunderclap headaches. This is a story of a 33-year-old school teacher. Her husband was in the Gulf and he returned from Gulf. She had a severe explosive type of headache at the time of orgasm. She got up, lasted for 5 minutes, she vomited and the headache subsided partially. 30 minutes later, another episode. She had a total of 4 episodes of severe thunderclap headaches till next morning 7 o'clock, and she was brought to casualty. The RMO felt that it can be a case of subarachnoid hemorrhage, but there was no neck stiffness, and the vitals were normal. And this was the CT angiogram of that patient. You can see that this is a normal caliber, then the area of vasoconstriction. Normal caliber, area of vasoconstriction. You can see areas of normal caliber and vasoconstriction, something like a cocktail, sausage on a string like this. So this is a classical case of reversible cerebral vasoconstriction syndrome, which is a relatively newly diagnosed, a recently popular diagnosis, but it's very common amongst us. Many times we never ask for an angiogram, and that's why we miss this. They can have a combination of hemorrhages or infarcts during the acute phase. So this is reversible cerebral vasoconstriction syndrome. It's easy to say the short form RCVS. And there are a lot of precipitating factors for RCVS, like postpartum or maybe drugs, especially alcohol binge can produce RCVS. Then SSRIs, nasal decongestant, our simple Otrivin nasal drops. If you use it in a susceptible person, it can trigger a RCVS. Then catecholamine secreting tumors, hypercalcemia. The list is big, but the commonest one in our setup will be hormonal pills and SSRIs and nasal decongestants. So beware of secondary causes in a patient coming with a sex headache, especially subarachnoid hemorrhage, RCVS, and arterial dissection. So first episode of sex headache, always investigate. Cephalalgia. This patient usually comes with a headache precipitated by sexual activity, and it usually starts with a dull bilateral ache, and as the sexual excitement increases, it becomes intense at the orgasm, and there is no underlying structural disease. So this is a relatively benign one. It keeps on recurring, but before making the diagnosis of a benign sex headache, you have to make sure that there is no significant underlying causes like an RCVS or an SH. Then, there are other nocturnal headaches also which usually come up at night. One is a space occupying lesions or increased ICT. I'm sure in your MBBS physiology classes, they would have taught you that any patient with a space occupying lesion, they have a worsening of headache in the early morning hours. Theoretically, there is a buildup of carbon dioxide, which causes vasodilation, and the headache worsens during the early morning hours. Then there is a group of primary headache disorders, which we call autonomic cephalalgias, cluster headache, SUNA, and many of them present at night as nocturnal headache. And there is a relatively benign variety called the primary nocturnal headache. But you have to be aware of this term called the trigeminal autonomic cephalalgia, a big group of disease and very peculiar ones, and they themselves form a nice title for a half an hour or 1 hour symposium. The classical things are cluster headache, SUNT, SUNA, and paroxysmal hemicrania. I will not go into the details of these headaches as such, but I'll give you a secret to diagnose. One is, think about these 3 A's in case of trigeminal autonomic cephalalgia. One is they are anteriorly located. That is mainly around the eye and the face. As you know, migraine is mainly in the forehead or the temporal region, but autonomic cephalalgia is mainly around the eye and face. The second is autonomic symptoms. They can have significant lacrimation, congenital congestion, or sweating of the face. And the third one, very important, is agitation, especially patients with cluster headache. They usually have a nocturnal headache. The patient wakes up, the patient becomes very restless because of severe pain. They can't lie down because of severe pain. They cry, they shout, they pull hair, some even hit the spouse. So they are very agitated. This is in contrast to migraine. In migraine, the patient prefers to lie down to reduce the severity of the pain. So anteriorly located, autonomic symptoms, and agitation, 3 A's of trigeminal autonomic cephalalgia. And this is a benign variety of nocturnal headache that's called hypnic headache. It usually occurs in females above the age of 50 and usually occurs around 2 to 5 a.m. They wake up from the headache, but this headache is not very severe like the trigeminal autonomic cephalalgia. And most of the time they wake up at the same time, and that's why this headache is known as an alarm clock headache. And the patient gets up, unable to sleep, they go for some work or they make a cup of coffee, and sometimes the coffee relieves the headache. So this is a hypnic headache. Now, after night comes a sunrise. Now, headache in the morning hours. That's also an interesting case. There's a 14-year-old male diabetic. He's an obese, again weighing 94. Every morning he wakes up with a headache, and this headache lasts for about 30 to 60 minutes. He also complains of mild memory loss, forgetfulness in the last few months. He has a fatigue. Every time in the daytime, he says, I don't have energy. and he tends to sleep off while driving or watching TV. So while asking history, he said he's got a lot of sleep. His wife said, മൂപ്പർക്ക് ഭയങ്കര ഉറക്കമാണ് പക്ഷെ ഇയാളുടെ കൂർക്കമലി കാരണം എനിക്ക് രാത്രി ഉറങ്ങാനേ പറ്റത്തില്ല. That is, I can't sleep because of his snoring. This fellow snores a lot. So this is a classical case of headache due to obstructive sleep apnea. And as you know, in obstructive sleep apnea, there is a slow build of carbon dioxide, and that produces vasodilation. So in the morning when the patient wakes up, they have significant headache, and it's bilateral, pressing in quality, and the headache usually resolves within 30 minutes. And you can see in the polysomnography, there will be significant sleep apnea. And usually they respond to effective treatment of sleep apnea. You put them on CPAP, their headache disappears. Then one interesting one is a cold stimulus headache. It's very common, and I'm sure 1/3 of us would have experienced it at least once in a lifetime. So when the palate is touched by ice cream or cold juice, they develop severe form of headache. Lasts only for a few minutes, but it's a severe one, and there is no specific treatment for that. You have to spit out the ice cream or the cold juice. You can keep a lukewarm water over there, or you can touch the palate with your tongue, and this ice cream headache will disappear. So this headache is also known as brain freeze. And nowadays 7-Eleven is marketing their what is that ice cream with this trade name of brain freeze. Then some rare headaches like external pressure headache, where there is a pressure of some external pressure on the scalp. This may be a small pressure, not producing any injury, but that can produce significant headache. And one such example is this ponytail headache. If they tie their hair very tightly, they can develop severe headache. And another one is with the advent of corona, we are wearing face masks. Most of us are wearing face shields and PPE kits. They also can produce significant external pressure headache. And there is a study from the Singapore University, and they found that about 81% of these persons wearing face masks and shield complained of headache, and usually lasts only for 2 or 3 hours after removing the face shield or mask. And the common areas involved are around the eyes and the temple. So this is an external pressure headache. Another very rare one is called the ice pick headache. You would have seen ice pick. So this is something like a sharp stabbing headache occurring on one side of the neck. It's very brief lasting, lasts only for 1 or 2 seconds. So before you realize that you've got a headache, it disappears. But for some unfortunate patients, it may come very frequently. Every 2 minutes or 3 minutes, they can develop a headache. It's very rare, and they respond very well to the indomethacin. And I said about different types of headache. Now the different distribution of headache. Sometimes the headache can occur as a linear headache or a zigzag headache. And another interesting one is a coin-shaped headache, also called the nummular headache. That is, the patient develops pain over a particular small region of the scalp at the size of a coin, and that's why it's called a nummular headache. The pain is generally moderate. When you touch the patient will feel something like an allodynia or a hyperpathia, and sometimes they have a local alopecia also, as in this patient. And if you press that region, the patient will get the pain. So you can actually reproduce the pain by pressing over that. The thing is that this is due to an underlying structural disease. This structural disease may be in the scalp or maybe in the underlying skull or below the skull. For example, a small vascular abnormality in the scalp can produce this one. Similarly, any serious disease in the skull or below the skull also can produce, like serious disease like a space occupying lesion or cranial metastasis or fractures or cysts. They all can produce this nummular headache. It's a very interesting one. It's a coin-shaped headache. For example, this patient is showing the area of his headache. It's a small area, and you can see there is a subrecurrent cyst sitting here. This patient has got a coin-shaped headache over the temporal region, and you can see a arachnoid cyst sitting there. So underlying lesions, calvarial mets. Again, there is a significant calvarial mets, and the only symptom the patient had was a nummular headache. So whenever a patient comes with a nummular headache, get an imaging to make sure that there is no underlying skull or brain disease. And coming to the last clinical case is a 75-year-old hypertensive person presenting with a temporal pulsating headache. And there is no vomiting, and you can see a very prominent temporal artery there. And the artery is tended to palpate. Investigation shows a high ESR of 110. The CRP is elevated. Even though headache looks very simple, it's a serious disease because it is temporal arteritis. And untreated temporal arteritis can give rise to significant blindness due to anterior ischemic optic neuropathy. So this is a criteria usually seen in persons above 50, and the new onset of headache, especially on one side with a high ESR, always think about temporal arteritis, and you have to act fast. Because if you don't treat it, they can develop ischemic optic neuropathy and severe visual loss. So my procedure was very particular. If he suspected clinically temporal arteritis, we made sure that the patient took 50 milligrams of prednisolone along with omeprazole in front of him before leaving the clinic. It's that much important. So at least whenever a patient comes with a unilateral headache for the first time, pulsating headache above 50 with a high ESR of above 50, think about temporal arteritis and give steroids. So my dear friends and seniors, I was given 20 minutes. I took you through a roller coaster ride through different types of rare headaches, and I want to make you aware that there is something more than migraine and tension headache and cluster headache in a headache clinic. There are so many things, and there's a big list of things that I told you: cough headache, exercise headache, headache, sex headache, RCVS, SH, and thunderclap headaches, most ominous one. Then low pressure headache as well as high CSO pressure headache, temporal arteritis. Then rare interesting things like ice pick headache, ponytail headache, mask producing headache, and ice cream headache. So atypical headaches are common, and many are due to an underlying serious pathology. You need investigations to rule out underlying structural causes, and a proper history is a must, as Dr. Madhusudanan has said. Proper history is always a must. Ask the patient about the onset, the distribution, what precipitates it, what relieves it, and how it progressed in the last few days. Hope you enjoyed my presentation, and I thank you for your patient listening.
Thank you, Dr. Hari, for the wonderful presentation. As usual, the Hari touch is there. That is what we all were expecting. And as the, we have got 2 more presentations, I think. Over to Dr. Joy sir.
Thank you, Dr. Hari, for the lucid presentation and in the wonderful way you presented. Thank you very much. This is the second time I am listening to your talk. The first one, as you said, Atma, death. Now we will move on to the next session. To the session, I will hand out to Dr. Ramkumar Menon for the continuation. Over to you, Dr. Ramkumar.
Yeah, thank you, sir. For the next session, we have 2 speakers. I'm sure everyone is aware of both of them. One is Dr. Arun Kumar, PT, who's a consultant ENT surgeon, and he heads the THANS, Thrissur Institute of ENT Head and Neck Surgery at Saroja Hospital, and he's the ENT surgeon at Atreya as well, and he works at Vincent de Paul and Son Medical Center. He has a special interest in endoscopic sinus and mid-ear surgery, micro-ear surgery, and coablative surgery. Having graduated from Government Medical College, Calicut, he went on to pursue his master's from Kottayam Medical College, and he's one of the few recognized coablation trainers in the state. And he has also trained in endoscopic ear surgery from Germany. He has represented, or rather he has actually headed the ENT club in Thrissur, and he also organized one of the international endoscopic ear surgery workshops in Thrissur in 2018. He's been the organizing secretary of multiple conferences. And the next person on the panel would be Dr. Rani Menon, who also needs no introduction. Having graduated from Calicut Medical College, Madam completed her ophthalmology from Kottayam and then went on to complete her fellowship from Edinburgh. And she currently runs the Dr. Rani Menon's eye clinic at Thrissur, which is one of the leading eye hospitals here, with a lot of modern facilities. And in the past, she held the position of Associate Professor at Amla Institute and has been the Chief Eye Surgeon at Manav Seva Eye Hospital. She has had multiple stints of training in India and abroad, and specifically, she's been with the NHS. And she has also acquired fellowships in cataract surgery and glaucoma. Presented multiple papers in national and international conferences. And she has a research publications in Kerala Journal of Ophthalmology. So the panel is open, and I request Dr. Arun Kumar to go ahead with this presentation.
Am I audible?
Yeah.
Yeah.
Thank you, Ramkumar, for the introduction. I'd like to thank IMA President, Secretary, and senior members for this wonderful opportunity. Also thank Dr.M.A.Andrews sir for chairing this session.
You want to share the screen?
I hope I'm visible.
Yeah, you are visible.
So after the wonderful talk by Dr. Haridas, I'll try to make a small presentation, go through the END cause of headache, and also talk something beyond the sciences. So I think we have already covered all these things by Dr. Haridas. Of course, the history is very important. Like he has mentioned, we take a detailed history regarding the onset, the progression, the frequency, the duration, location, character, severity, or other symptoms like eye, ear, nose, and precipitating and relieving factors, other medical history. Because we can get a fair, good idea about the whether it's a cyanogenic or other cause of the headache. So again, Haridas has already mentioned this. This just shows we can generally make out whether it's a tension headache depending on the site of the presentation, whether the headache is like a band around the head or whether it's a unilateral one like a migraine or something around the head like a cluster headache, and so on and so forth. So coming to sinusitis, which is our bread and butter, the headache is seen only in acute sinusitis. In chronic headaches, chronic cases, we see only a feeling of pressure, fullness, or a throbbing type of headache. And it's basically in the distribution of the paranasal sinus or the vertex of the head. So sinusitis with or without polyposis also can cause headache. So actually headache is a minor criterion for diagnosing the sinusitis. So the major symptoms are facial pressure, pain or pressure, nasal obstruction or block, nasal discharge or purulence, hyposmia or anosmia, and purulence in the nasal cavity. So the minor symptoms include headache, fever, halitosis, dental pain, cough, and ear pressure. So complications of sinusitis causing headaches are orbital cellulitis, osteomyelitis or Pott's puffy tumor in relation with the frontal sinus, the cavernous sinus thrombosis, biomucosal or maxillary antrum frontal or sphenoid, and other intracranial complications like a subdural intracranial abscess and meningitis, and so on and so forth, which I think the neuro will be key. So, few other causes of headache include the fibrous dysplasia, osteoma of the airpods, frontal sinus, or the sinulets. Sinuletial malignancy is also present with headache. Then we have invasive fungal sinusitis and the skull-base osteomyelitis. And this is one interesting thing which is coming in the incidence is rather increasing because of the COVID situation. This the rhino-orbital cerebral mucormycosis, especially seen in immunocompromised individuals. They are present with epistaxis, proptosis of facial skin necrosis. The important thing is that this progress within days to meningitis, and it's a very fatal disease. The pathology is the invasion by the fungus, which causing the thrombosis and necrosis of the surrounding tissue. So this is the classical sign of the mucor. That is a black necrotic eschar or a black necrotic turbinate. You just look into the nose, and if you see something black there, you can take it from me. That is this mucor. And the thing is that this is pain. It's not sensitive to pain and it doesn't bleed on touching. So the treatment consists of wide debridement till you get the bleeding tissue, and followed by IV liposomal amphotericin. Because unless you remove this all the necrotic tissue, the drug is not going to reach there and it's not going to be effective. So we give this in the dose of 1 to 1.5 milligram per kilogram per day to a maximum 3 grams, which is the full course. And you can step down with savuconazole, which is recent one, or you can give posaconazole or voriconazole. So coming to something beyond the sinuses, the series of leak. I think Hari has already covered the low pressure headache in relation with the spinal CSF leak. So our main area is the cranial CSF leak, which presents as a watery rhinorrhea, a salty with a metallic taste in the mouth. There's a sense of drainage in the back of the throat. Sometimes if there's a temporal bone lesion, you can get a CSF autouria also, which can come through the nose. And radiology, we depend on CT of the paranasal sinus. CT cystoscopy was one of the diagnostic thing which we were doing. MRI, the fat suppressed T2 weighted imaging is a very useful tool which shows the CSF as a bright signal. We can also do a radionucleoside study. This is just a small video showing the CSF leak. If you look here, you can see the watery, clear watery nasal discharge, which I am collecting it for beta-2 transferrin test. And see that you can see that. So this is the classical sign, the drip through the tip, that clear fluid. So you can do a glucose oxidase test using a Bendix reagent. You can, or you can go for a beta-2 transferrin, which is 100% sensitive but costly. And this is the latest one, which is a beta trace protein. It's 100% sensitive and specific. This is an immunological marker. In CSF, it's around 18.4, whereas in serum, it's the concentration is 0.59 milligram per liter. So again, you can do a nucleotide study. So this is the MRI cystonogram, which has superseded the CT cystonogram, which shows there's a small meningoencephalocele along with the CSF. So this gives the MRI gives more information for a surgeon. Another technique which we can use is a 1% fluorescent given intrathecally. That shows where if you don't find an active CSF leak, you can try that on the term. So you can see the fluorescent here, so you can visualize the defect in the earth marks. This is one the cribriform plate. Okay, this is another one which is causing headache. Again, it's a combined neuro ENT approach. We can go to you can remove the pituitary adenoma. In this case, which is an adenoma, which is removed through the transnasal route with a forehand technique. ENT and the neurosurgeon working together. So investigation, coming to the investigation, you know the X-ray of the paranasal sinus, we take HRCT of the paranasal sinus, the MRI, everybody knows that. So I'm not dwelling on that. Then this is the new kid on the block, which is a cone beam CT, which has come into the picture. It is actually a unit which basically for dental thing, but it has found to be very useful in the ENT segment also. The thing is that it gives you the axial, coronal, and the sagittal cuts along with the 3D reconstruction in one screen. The thing is, the interesting thing is the radiation is very, very low. So repeat CTs are all very safe in this particular using this instrument. So other causes, septal causes, we have the septal abscess, hematoma, septal spur, causing the contact headache, then fractures, and infections like vestibulitis in the dangerous area of face. Concha bullosa, that's a pneumatized middle turbinate. This also can cause headache. It can cause, because of the blockage, it can cause recurrent acute headache, recurrent sinusitis. And a simple test to identify, you can put some decongestant and then see whether the headache is getting relieved. And neuralgias, I think Hari has already covered, so we call it the Haridas neuralgia or the spinopalatal neuralgia. Coming to the otological causes of headache, it's a complication of CSOM, like subdural abscess, temporal lobe abscess, epidural abscess, and we have the petrositis causing the Gradenico syndromes. Okay, and this is the new one, which is increasing in incidence, the malignant external otitis. We see nowadays the incidence have gone up. We're getting a lot of patients with the malignant external otitis. Usually start with a trivial injury to the external canal using a cotton bud or something, and then it is progressed to a skull-based osteomyelitis. That's the issue here. So, and it is the 95% it is caused by Pseudomonas. Of course, we have staph also and sometimes we get fungus also there. But it's 95% it is a Pseudomonas infection. It is causes severe otology and headache. The major criteria for diagnosis include the pain, which is not in proportion to the physical finding. Then you have the edema of the canal, exudate, granulations in the external canal. Gives a positive technetium 99 scan gives you the diagnosis. Causes lateral skull-based osteomyelitis. I've seen patients with even multiple granular palsy, something like Werner syndrome. That's a 9-10-11 palsies, granular palsies. This problem is it requires prolonged antibiotic treatment and diabetic control. Strict diabetic control. Fungal infection also can coexist, and the surgery's role is very, very limited in this situation. Okay, coming to children, we have acute ethmoiditis or acute otitis and acute coalescent mastocytosis, which can cause headaches. And just to touch upon the oral cause of headache, any infections in the oral cavity, the emerging or impacted wisdom tooth, that can cause headache. Most of the time we see temporomandibular joint creating patients dysfunction creating headaches. So the diagnostic criteria, the flinching part is if you press on the temporomandibular joint, you get a severe tenderness. So that gives you the clue about the TMJ disorder. And you seen mostly in patients with bruxism or someone like this loss of last molars, so they try to chew on one side. Very, very common. And individuals with severe tension. The treatment is anti-inflammatory, and the low dose amitriptyline gives you good response. Sometimes we'll have to use injection, silicane, or some steroid injection, or even botulinum can be tried in resistant cases. Of course, this again, just to complete the thing, cervicogenic headache again covered. So, thank you very much for the questions.
Thank you, Dr. Arun, for the discussion on sinuses and beyond, sinuses for causes of headache. I think the questions and answers can be at the end of the session. Dr. Ramkumar, may please introduce the next speaker, Dr. Rani Menon.
Please unmute and talk. Please unmute. Dr. Ramkumar, please unmute. Please unmute Dr. Ramkumar. Dr. Ramkumar, please unmute.
Yeah, hello.
Thank you.
Yeah. So I actually introduced Dr. Rani already, but I'll do that again. Pleasure.
Okay.
So for people who were not there, Madam, as you all know, is owns the Dr. Rani Menon's eye clinic, which is a very leading eye hospital in Thrissur. And she graduated from Calicut Medical College and completed a master's from Medical College Kottayam, and subsequently went on to complete her fellowship program from Edinburgh. She has held the position of Associate Professor at Amala Institute and has been the Chief Eye Surgeon at Manav Seva Eye Hospital. And she is trained at NHS in UK. She's also worked in Baby Memorial in Calicut and had a stint in Saudi Arabia. She has had multiple fellowships, starting from Arvind Eye Hospital, and has had multiple presentations, both nationally and internationally, and has also published an original research article in Kerala Journal of Ophthalmology. So without taking much time, I would hand over everything to Dr. Rani Menon. Welcome, ma'am.
Thank you so much. Can you hear me?
Yeah, we can. Yes.
Okay. Thank you for that great introduction, and thank you IMA and Dr. Ramkumar for asking me to do this. So I'll just quickly enumerate a few causes of ophthalmic causes of headache, as I was told to do, and I promise I'll make this very quick. So starting from refractive errors. So everyone thinks refractive errors is the commonest cause of headache in ophthalmology, but in actual practice it's not. It's usually a misconception, but generally people do come to the ophthalmologist thinking that a change in power of their glasses is causing their headache. So that's in one way good, because that's otherwise they will never come for a checkup. So starting with hypermetropia is one of the commonest causes of headache here. So you can see that this one here, this is the image that the patient sees. This is the image the patient with hypermetropia sees. See, it's a very blurred image, and this is the normal vision. So if a patient has this kind of a blurred vision, he would strain.
Sharing the screen.
Sorry?
You are not sharing.
Slide is not.
Oh, sorry. Okay.
5
minutes.
തീർന്നല്ലേ അത് മതി 10 minutes ആണ് പറഞ്ഞത് അപ്പൊ അതിന്റെ ഉള്ളിൽ പറപ്പിച്ചു കൊറേ സ്കിപ്പ് ചെയ്തു എന്താ വെച്ചാൽ ഏതെങ്കിലും അത് പോറോ കാരണം കുറെ കാര്യം കവർ ചെയ്തിട്ടുണ്ടോ സ്റ്റുഡൻസിനുള്ള സാധനങ്ങൾ എന്താ പോറോ
Share the screen. Are you able to see the screen now?
No.
Okay.
You have to agree. PowerPoint open to share the screen.
PowerPoint.
Where is it? PowerPoint open to share the screen.
That's just a PowerPoint.
Microsoft PowerPoint.
Yeah, okay. Is it okay now?
Yeah.
Yes.
Right, thanks. Thank you, Keshav. Okay. No, this was over, and this is actually the screen I was on. Are you able to see this now?
Yeah.
Okay, this is the hypermetropia image that I was talking about, and this is a very blurred image here. So this is what the patient sees with the hypermetropia sees. So in order to make this image clear, he or she strains his ciliary muscle so much that so there is a headache and eye strain. So that is one of the causes of headache, hypermetropia, which is uncorrected. And secondly, this is the image of a patient with astigmatism. I mean, this is how the patient sees the lights. You can see that the lights are all in a coma, or it's an oblique light. It's not a straight point. So whereas this is the normal image that the patient should be seeing. So in order to make this image clear, the patient makes his eyes into a slit and tries to look through the slit. So this again causes his eye strain and headache. And the third common cause of a refractive error is presbyopia. When a patient gets above 40 years of age, he or she actually fights with himself not to use glasses. So what happens is, so the patient does not use glasses to read, and this causes a strain after reading for some time, and the patient gets tired eyes, and it goes away after resting a bit. So I finally, after some time, what happens is the patient loses all interest in reading and near work, especially if his job doesn't demand that. So nowadays with the accommodative spasm is one of the very common causes. With the overuse of computers, small screens, big screens, what happens is the ciliary muscle continuously is put into work when the patient is doing close work, and this is when the ciliary muscle goes into a spasm, and when it goes into a spasm, it causes headache. Again, so some of the newly acquired myopia. Sometimes we are seeing a lot of spurt in myopias, minus powers. So this is also one of the causes of a newly acquired myopia. So if you ask the patient to rest for a while and do the test again, then this myopia might go away, as well as his headache. Now, this is the opposite of myopia, where this is a convergence insufficiency. Normally, these eyes should converge when the patient is looking at a very close object. Whereas in convergence insufficiency, this one is looking at the near object, whereas this one is deviating outside. So this causes a lot of eye strain to the patient, as well as double vision while the patient is looking at close things. This is more common in children. And again, coming to the secondary causes of headache, which is our ophthalmic causes, dry eye is a very, very common cause of headache. It's especially in the elderly people. You can see that the cornea is lacking luster here. This is the green fluorescein stain that we have used to see all the bright staining spots on the cornea. Then uveitis. Uveitis is another important cause of headache, where you can see that the eye is all red and there is a hypopion here. This is actually a pus in the anterior chamber. This pus means it's not because of any injury or anything, but these are WBCs settled inside the anterior chamber. So one clue for the diagnosis of uveitis is that the eyeball will be very tender to touch. If you just touch the eyeball, the patient will have severe ciliary tenderness. So this is a one clue for uveitis. Then one of the most important one, or one of the least emergencies in ophthalmology. So actually ophthalmology doesn't have a lot of emergencies, but one of the biggest emergency in ophthalmology is an acute angle closure glaucoma. Here you can see that the eyeball, the pupil is dilated and fixed, and the cornea is very hazy. So this patient will present with a very severe headache, defective vision, and redness. Sometimes the patient will also have headache. Headache will always be there, but sometimes patient will have vomiting. So this is an emergency because we have to bring down the pressure immediately, otherwise the patient will lose the vision. So in my clinical practice, I think I have seen a lot of migraine cases. If it's a young patient, it's commonly a migraine. And if it's an elderly patient, it's a tension headache. Tension headache, migraine, Dr. Haridas has beautifully explained. So I'm not going into all the details now. Whereas in tension headache, you will see that the tension headache is more towards the evening, and the patient will describe it as a band around the tightening band around the head. And also sometimes migraine, it's very important to ask the positive family history in the patient. So a positive family history gives a big clue for migraine. So also if you can ask a history of motion sickness as a child, that would also give a clue towards migraine. And another thing that I have seen practically is young children have been brought to me with complaints of frequent blinking of the eyes. And if you take a history, invariably there will be a history of mobile overuse, plus there will be a family history of migraine. So you just ask the child's parents to take away the mobile phone, and this symptom of frequent blinking will go away. And now papilledema. So many a time we ophthalmologists have been able to detect brain tumors by a chance finding, chance examination of the fundus. So this is a case of papilledema, like it has been explained before. It can be a true intracranial tumor or a benign intracranial tumor or an idiopathic intracranial hypertension. But these, whatever be the reason for I mean, whatever be the reason for headache, if the headache is chronic, if the headache is a chronic one, and if the patient so please don't hesitate to do an imaging. That is what I really want to stress at this time, because many tumors have been missed because of lack of doing MRI or imaging. And I don't know why we doctors are really hesitant to ask for MRIs. Maybe because there are a lot of malpractices going on. I don't know what. But I think we should give more importance to imaging if the headache has been there for a long time. So in summary, so I would like to summarize this now. Take a very good history. A good history is very important in migraine. And also you can ask for any pain in and around the eye. If there is a headache, if there is a defective vision, all this will point out towards an ocular pathology. And like I said earlier, please feel the eye also, so that you can feel any tenderness in the eye. And finally, not at all last and not a bit in the least, have a very, very low threshold for imaging. So do an MRI or MRV, and let's not miss any intraocular tumors. So this is the most important thing I have to say. Ocular causes, anyway, if there is any ocular pathology, the patient will come to you. But many tumors have been missed because of lack of taking MRIs. Thank you.
Okay. Thank you, ma'am, for the brief and a crisp presentation of ophthalmic causes of headache. I think it is time for a panel discussion. Dr. Haridas has pointed out that hypoglycemia can also produce headache. Many of us might have started attending the CME at around 6:30, and it is already 9:45.
Sorry to interrupt. Screen sharing on the disable you, Dr. Rani.
Sorry. Yeah.
So we'll be very brief. There are a few questions. The panelists are all here, I hope. First question is to Dr. Ramkumar. The question is there any surgical management for cluster headache?
Neuromodulation is what is attempted in cases of cluster headache or any of those kinds. So there are a lot of neuromodulation techniques. So they say occipital nerve stimulation, trigeminal nerve stimulation, vagal nerve stimulation. Personally, I have no experience with neuromodulation.
Any role for the sphenopalatine ganglion stimulation?
Yeah, that is also. That is also known to happen. In fact, stimulation as well as ablations, both are done.
Sir, can you highlight something on that?
Yeah, same thing. Spinal ganglion block or stimulation, both are effective in preventing cluster headache. Yeah, that is one of the neuromodulation technique in hypertension.
Sir, previously lignocaine was used to anesthetize the. Is it going on now? Is it useful?
No, not now. They're mainly for stimulation or stimulation studies.
Okay, sir. Thank you, sir.
May I add?
Yeah.
Dr. Hari, please.
2 decades back, when we were in a primitive state of neurology, my friend Arun, the ENT surgeon, used to do a local block of the nose. Like he used to keep a, he used to apply lignocaine over the upper part of the nose to block the spinopalatal area. And we used to get good results in patients of cluster headaches. You can ask Dr. Arun if he's around, like if he's still doing that. I remember 2 patients, they had a very dramatic relief with the lignocaine block. He used to do it endoscopically and do that.
I think there is some renewed interest in this topic. There are some articles stating the usefulness of this procedure. I think in your Atreya hospital, you may start and do your research there.
With all your blessings. Yes.
Sir, second question is to Madhu sir. The question is, how will you differentiate vestibular migraine from vestibular neuronitis? That is a question raised by one of the.
Yeah, the vestibular neuronitis is an acute event. A single episode of prolonged vertigo vomiting, that's vestibular neuronitis. Vestibular migraine, you diagnose as episodic vertigo. If the only thing, just like migraine episode, the coccus recurs, the vertigo also recurs in vestibular migraine. When the patient comes to the first episode of vertigo, prolonged vertigo with vomiting, lasting for about many hours, it's likely to be vestibular neuronitis rather than a vestibular migraine. If that vertigo recurs again and again with any other premonitory symptoms, associated symptoms of migraine, then you can diagnose vestibular migraine. A single episode, you can just by diagnosing it. Just like headache for the first time coming out in this first episode of migraine, difficult to diagnose.
Sir, we used to say previously basilar migraine. Is it similar to vestibular migraine or same?
No, that's totally different. But vestibular migraine is associated with brain symptoms like diplopia, paresthesia, they can occipital phenomena. So that's usually seen in younger individual, and that the aura is a bit more prolonged than the use conventional aura. So that's different from the vestibular migraine.
Okay. One more question is to sir. How will you differentiate convulsive syncope from seizure? That is it.
Yeah. In convulsive syncope can have few jerks, especially myoclonic jerks can occur. That occurs only when the patient is made to sit up. Suppose you develop loss of consciousness. The bystanders make the patient sit up. They may not allow the patient lie down. They can have few clonic jerks. But they never last for a long period of time and subside the moment the patient regains consciousness. So that's how you can differentiate convulsive syncope. The patient is made to lie down, their myoclonic jerk disappears. On the other hand, seizure, the myoclonic jerks continue to occur. It is secondary to hypoxia itself.
Dr. Hari has raised a question, not question, comment. Hypoglycemia can produce headache. Some of the book says there's something called a coat hanger headache. Sir, what is your experience and comment on that, sir?
I don't know, sir. We'll ask Dr. Madhu.
Coat hanger headache is headache felt in the neck, back of the head, and to the neck and shoulder in persons who have got postural hypotension. When they develop BP fall when they upright, they get headache in the neck and back of the head. That's called coat hanger headache. That's just a BP fall during upright postural hypotension. That's a postural hypotension.
So these are the main questions. And I think hypoglycemia is also should be considered because many people with migraine, they used to say headache is precipitated by hypoglycemia probably. And I think one more thing, this herpes sometimes make you you will investigate for some days and somebody comes with a severe headache, especially ophthalmic herpes. You forget to look for the vesicles, 1 or 2 vesicles may be there. That is often misdiagnosis. The herpes presenting with severe headache. There is one comment I had to say regarding headache.
Yeah, very true, very true, very true. Unless you look for that, you will miss it.
I think we have justified that we will be spending only 10 or 15 minutes for the panel discussion. If there are no more comments, I think sir can make a final comment on headache and these things, and we will wind up the session, sir. Over to Maz.
Yeah, only no. The only thing is, Andrew, you look like a Christmas father. Eh? Because I am very ashamed to say that I am your teacher. You look like my teacher.
So the statement is, sir, you learn less from your teachers, more from your more from your colleagues, and maximum from your students.
Nothing to say. Thank you for inviting me to be part of this program.
So for everybody's information, Madhusar has written a very beautiful book, Higher Functions, and I think Dr. Santosh has promised to give 9 books to somebody. I don't exactly remember. Is Dr. Santosh there?
Yeah, he's there.
Okay, over to Joy sir and Dr. Santosh for the first of the proceedings.
Dr. Santosh is there around. So still I can see you. Dr. Santosh, please unmute and talk. Hello. I think he is not there. Dr. Santosh? Just a moment, I will call him.
Doesn't matter, you can wind up, no problem.
Hello. Hello.
Yes.
Am I audible, Joy sir?
You're audible.
Okay. I was watching all the proceedings. Everything went on very well. A few more questions were actually we are offering books for best questions. Only 2 candidates are selected, so we have 7 books pending. So we will give that books through by post to the question people. We know the mobile numbers and we ask them and send that book. This book is available in Cosmos. It is an excellent book. It's a short book. I think every doctor should have, not only the resident and not only the clinical practitioner. It is available in Cosmos, and the version is also available in Amazon. Wonderful book. So I would ask everybody to purchase the same book, and the best questions selected, the question whoever has asked the questions will get the book by post.
Declare best questions in there.
Dr. Binish and Saya Santosh.
Thank you.
Okay.
Okay. Thank you for the wonderful session, and I'm happy to see we have got except Dr. M Madhusudanan. All the faculties of today's CME are IMA members of Thrissur. A galaxy of stars we have got, and I am proud of it, and I am proud of to be the president of this galaxy of stars, even though I am not a faculty. Anyway, thank you to all. Now I invite Dr. Pavan, our secretary, for the final vote of thanks. Over to you, Dr. Pavan.
Yes, thank you, Joy sir. I have officially thanked everyone previously. Anyway, once again, I am thanking all our senior members and all the faculty members for joining us today, especially Madhusudanan sir and Rammohan sir. Thank you once again for arranging today's CME session, and thank you extending my thanks to all the faculty members and to IMA Thrissur members for attending. We had members from other branches as well who attended. Thank you once again. Thank you so much.
Thank you, Dr. Pavan. We have got members from all over India. I have seen some other North Indian members also. Thank you all for participating in our webinar. Now I am very happy and proud of you all. So
Okay, good night.
good night and thank you for
Night.
the thank
Haridas, good night.
Good night.
Sir,
no,
Andrew,
yes, okay.
Andrew.